Hello guys, welcome to our channel. Today we'll be discussing about the most important topics and the sure shot expected topics of the FMG examination for the upcoming session. So I have divided into the three parts. So this is our first part, and in this all three parts we will be discussing 150 plus topics. So I'm not telling that all the 150 plus topics will be coming in the exam, but in the realistic expectations and the last 2 years feedbacks what we have done before, so we are expecting at least 80 plus topics from this sure short series. So please do watch these three videos, and I'm going to tell you now at least 50 plus topics, and the concepts which will be repeating will be very much helpful for your upcoming examination to boost your score. Okay, so let's start the session guys. Those who are new to this channel, please to subscribe and share with your friends, and do watch all 19 subject rapid revision videos in this 7 days, and also do watch this short short series. Okay, then definitely these all going to help you a lot. So let's start the session guys. So first and foremost important, epithelium. So epithelium and the cartilages from the perspective of the anatomy, this is one of the most important topics. So we have the different types of the epithelium. So the squamous epithelium, cuboidal epithelium, and the columnar epithelium. So the description is characteristics is far not expected in the examination, but the locations are very important. So the simple squamous epithelium is present in the lung alveoli, heart lining, and the simple cuboidal epithelium is seen in the terminal bronchial and the renal tubules. And simple columnar epithelium is present in the uterus, intestines, and the uterine tube. Pseudo-stratified columnar epithelium, this is very important. It is present in the trachea, bronchi, and the upper respiratory tract, for example larynx. And next, pseudo-stratified squamous epithelium is present on our skin, esophagus, oral cavity, vagina, cervix, and the cornea. All this will be covered with the stratified squamous epithelium. Next, stratified cuboidal epithelium is present in the sweat glands, salivary glands, mammary glands. Stratified columnar epithelium, male urethra, gallbladder, and also glandular ducts. And transitional epithelium, another important point, this is present in the bladder, ureter, and the urethra. And these all questions can be expected in the examination. And also where the cilia is present, if you can observe, it is present in the simple columnar epithelium and the pseudo stratified columnar epithelium, right? Next, moving on to the cartilages. In the cartilages we have the three types of the cartilages: hyaline cartilage, elastic cartilage, and the fibrocartilage. And hyaline cartilage is present in the larynx, trachea, bronchi, costal cartilages, and also synovial joints. Next, elastic cartilage. It is present in the external ear and external acoustic meatus, auditory tube, and the larynx. Fibrocartilage is present in the intervertebral disc, pubic symphysis, sternoclavicular, temporomandibular joints. So, what are the importance of this particular cartilages? So, the function one, it resists the compression. So, the hyaline cartilages will resist the compression and also act as a cushioning and the smooth lower frictioning surface of the joints, and it forms the foundation of developing fetal skeleton. Next, there is elastic cartilage which will be important for the flexible support for the soft tissues, and fibrocartilage which will be resist the deformation under the stress. And what is the collagen that is present here? The collagen that is present here is the type 2 collagen. And what are the main cells? Chondrocytes and the chondroblast. And if you can see, there is a another dermatosulfate or the glycon sulfate, chondrin sulfates. These are the glycosaminoglycans, right? In the cartilage we have chondrin sulfate. Okay, so the chondrin sulfate is present in this cartilages. This is the most common presentation. Next, this is the important point. At least one question we can expect from this topic. Next, coming to the joints. Joints, very easy question we can expect, right? So in the joints, whenever you are looking at the joints are divided into the three types. Okay, so joints are divided into the three types. One is the fibrous type, okay, immovable, it does not going to move. And cartilaginous is slightly movable. And the last one, which is the synovial joints are more flexible and movable. Okay, so this is immovable, and this is slightly movable, and this is movable joints. Let's see those examples. Fibrosis, fibroid joints, which is divided as a three types: sutures, syndesmosis, and the gomphosis. Sutures examples you all know: coronal sutures, right? Our skull, which will be connecting all sides, that is known as a found only in the skull, which will be connecting the bones, that is known as a sutures. Next, syndesmosis. Syndesmosis is the joint which is held together at by the ligament. So for example, this is the one bone and this is the another bone. So these both has to be joined together, this ligament, that is known as a syndesmosis. Gomphosis is like that, this is our tooth, right? So tooth has to be fit in particular socket kind of. So that socket kind of is a fibrous joint, that is known as a gomphosis. For example, imagine if our teeth is moving, mostly our teeth will be fixed. So that is what the fibrous joint, it cannot be movable. Next, moving on to the cartilaginous. This is the type of the one cartilaginous. This is the secondary type of the cartilaginous. So primary cartilaginous joints such as known as a synchondrosis. Examples is the epiphyseal flat of the growth physis, and also sternomanubrial joints. Okay, sternomanubrial joint, especially at the first rib and the sternum. Why this sternomanubrial joint is important? For example, if you want to take the breath, if you want to move the always the sternum, it will be difficult, right? It can cause the puncture also. So that's why this synchondrosis, which is lined by the hyaline cartilage, that is not going to be movable. And symphysis, another type is a fibrocartilage, and this is will be seen in the pubic symphysis, and also fibrocartilageous vertebral disc, which will be connected by the fibrocartilage of the symphysis, and this is slightly movable. And these are also immovable type of the joints, cartilaginous joint. Next, moving on to the synovial joints. Synovial joints, as we discussed, they are movable. So synovial joints examples, we have the pivot joint. Where is this pivot joint is present? Atlantoaxial joint, right? Atlantoaxial point, this joint is presented. When you do the yes or no, what is moved? No, at the time of the no, the atlantoaxial movement is seen, right? So that is present with the pivot joint. And next, hinge joint. Hinge joint is seen in the elbow. And next, saddle joint is seen in the trapezium carpal bone and the first metacarpal bone. And plane joint is seen in the tarsal bones. Condyloid joint is seen in the radius and the carpal bones of the wrist. And ball and socket joint is seen in the shoulder joint and the hip joint. These are the joints and their associated examples. Next, moving on to the another simple questions that can be expected, that is the dermatomes. Dermatomes is different from the whatever the locations with the vertebrae. So dermatomes is vertebrae is different. We have the thoracic, lumbar, and different vertebrae. But we have the dermatomes. This is due to the nerve supply that is coming from the peripheral nerves of the dermatomes. For example, let's see. So all the cervical, which will be applying up to our limbs, that is seen with the cervical, and also thoracic will be supplying for our upper trunk, and both the lumbar and the sacral, which will be supplying the both the lower limbs. This is how it is presented. And in this, some important questions can be expected. So the frequently on the last examination, they have asked what is the thumb supply. So here you can see this is the thumb, right? So thumb supply, which will be seen with the C6. Okay, thumb supply will be on the C6. And also, what is the supply of the neck? So neck supply will be seen with the C2, C3. That is both are seen with the neck and neck region, which will be supplied. Next, coming to the big toe will be supplied by the L5, and lateral fingers, which will be supplied by the S1. And also this is the anterior, right? So this is the anterior we are looking at, this is the posterior. On the anterior, this is how the lower limb will be look like: L1, L2, L3, L4, and the L5. But when you see on the posterior aspect, on the flexor aspect, if you see, it is different, where you are going to see L2, which will be the more lateral side, S2, which will be the medial, and L3 will be more medial, and L4 and the L5, and higher aspect of the most the ankle joint, which will be supplied by the S1, right? This is the questions can be expected in the examination. And complete palmar, which will be supplied by the C5, C6, C7, C8. Little finger will be supplied by the C8, and 3 middle fingers will be supplied by the C7, and thumb will be supplied by the C6. Okay, so repeat after me. These important points can be expected. So thumb, which will be supplied by the C6, and big toe, that is the metatarsal, which will be supplied by the L5 on the anterior aspect. What about the posterior aspect? In the posterior aspect, it is supplied by the L4. Next, coming to the neck region, which will be supplied by the anteriorly, it is supplied by the C3 and the C4, right? C3 and the C4 will be supplied. Next, coming to the anus, anus will be supplied by the S5 of the dermatome, and the nerve supply of the whole hand, like there is a fingers, right? So first, second, third, fourth, and the fifth. Fifth will be supplied, this fifth finger is supplied by the C8, and these three fingers is supplied by the C7. First finger, this is thumb, thumb will be supplied by the C6. Okay, so these questions has to be, can be expected in the examination. Next, coming to the umbilicus, umbilicus will be on the T10. Umbilicus will be on the T10. Next, there is a skin lines which will be differentiating Blaschko lines and the Langerhans lines. So Langer lines, which is known as a tension lines, this is important for the surgical implications. Okay, for example, when we are want to make an incision here, so we are going to make parallel to this skin tension lines. Why this important? Because it is going to cause the minimal scarring and optimal healing will be seen with this Langer lines, and it is going to look like this only. Dermal collagen bundle orientation, which will be looking like this triple helix structure we are going to see. Whereas Blaschko lines is actually known as a embryological development. They have the different shapes. For example, old appearances or the V appearances or the curly appearances. This is we are going to see. And embryological, if there is a defect in the embryology, obviously that is going to seen as a disease. So that disease, which is known as a incognitia pigmenti, which will be associated with the Blaschko lines. Next, moving on to the nerve supply and different types of the nerves and their injuries that we are going to discuss now, right? So first two important discussions that you have to see, Erb's palsy and the Klumpke's palsy. What is the nerve root that is involved in the Erb's palsy? C5 and the C6, and the Klumpke palsy, this is the C8 and the T1. So this is the lower trunk and this is the upper trunk, right? So what are the defects that the patient will be having? Here there is a defect of the axillary nerve and also musculocutaneous nerve and the suprascapular nerve. All these nerves will be disturbed in this patient. So when you look at this picture, you are going to see this is look like a waiter tip deformity or the pole is dip deformity. And C8 and T1, this is going to involve the sympathetic chain. This will be involving of the sympathetic chain and also ulnar nerve, which will be disturbed here. So if the both will be happen, so this is going to cause the Horner syndrome. This is going to cause the Horner syndrome. And ulnar nerve, which will be involving of the claw hand. Claw hand will be seen in this patients. Okay, these are the defects that you are going to see in the Erb's palsy and the Klumpke's palsy. And here in the Horner syndrome, either it could be due to trauma, for example, the Klumpke's palsy, or it could be associated with the Pankos tumor also. And you have to know about the Horner syndrome symptoms. What are those? The patient will be having meiosis and also anhidrosis, ptosis, okay, loss of ciliary function, loss of ciliary function. Effectively, this is seen with the highly associated with the eye condition that is known as a Horner syndrome. Next, understand this importance of the each image, guys. Image based question can be expected here. So this is seen with the median nerve injury. Median nerve injury. And what is this condition, guys? The condition here you are looking at the ape thumb deformity. This is known as a ape thumb deformity. Alright, and in the ape thumb deformity, especially in the children, it is seen with the supracondylar fracture. Supracondylar fracture. Next, coming to the another picture here, you can see this is known as a claw hand, but this is a partial claw hand. Again, this is seen with the ulnar nerve damage. Next, here this is the wrist drop. This is the wrist drop seen with the radial nerve injury. This is seen with the radial nerve injury. And here this is the foot drop. This is the foot drop seen with the patients of the common peroneal injury. Common peroneal nerve injury. And where is the fracture? This is fracture that you are going to see if the fibula is fractured. Fibula head is fractured, that is going to compress the common peroneal nerve. Next, here you can see another picture. This is seen with a hypoglossal nerve injury. This is seen with a hypoglossal nerve injury. Hypoglossal nerve injury, the palsy, which will be seen here. For example, this is the normal side and this is the lesion that the patient is having. Where is the deviation? Deviation will be seen towards the normal side. Deviation seen towards the normal side where the lesion is associated with the hypoglossal nerve injury. Next, here you can see this is the clavicular injury. Where is the junction? The junction of the clavicular injury will be the half lateral, one third of the lateral and the two thirds of the medial part. The junction is involved. And the most common overall injury if there is a fracture, that is the clavicle fracture that you are going to see. And what is the bandage that we use? Eight-shaped bandage is used for the fixation. Next, see the nerve injuries. See the nerve involvement. So this is the palmar aspect and this is the dorsal aspect, right? On the palmar side, so the first three fingers is supplied by the median nerve, okay? And lateral two fingers which will be supplied by the ulnar nerve. And on the dorsal side, it is supplied that all the digital fingers or the nails which is again supplied by the medial nerve and the last two fingers to the lateral side which will be supplied by the ulnar nerve, but the dorsal aspect of this region, particularly the one third of the region which will be supplied by the radial nerve. So imagine if you see the question, they're telling that on the dorsal side first three fingers are anesthesia or patient can't feel, that means it is involvement of the radial. If they say same picture but on the palmar side, then it is a median nerve injury. Next, here you can see this is the humor. So our longer bone of the shoulder. So if there is a fracture on the neck, this is the surgical neck fracture. If there is a fracture here, this is going to involve the axillary nerve. This is going to involve the axillary nerve. This is a spiral groove. If there is a fracture at this spiral groove, it is going to involve the radial nerve. It is going to involve the radial nerve. And here, this is a supracondylar lesion. If this is involved, supracondylar in individual, they can have the injury to the median nerve and the artery that is involved anterior introitious, sorry, if there is a artery involvement, that is a brachial artery. But supracondylar have the controversy. If you want to choose the supracondylar, better choose the AIN, anterior introitious nerve. If there is no option, then go with the median nerve. And here you can see this is a lateral condyle and the medial condyle. And if there is an injury to these regions, here ulnar nerve palsy will be seen in this patients. Okay, ulnar nerve palsy will be seen. Next, some of the defects here you can see the patient is having the shoulder drop. Why the shoulder drop will be seen? So shoulder drop will be seen due to spinal accessory nerve injury. This is due to spinal accessory nerve injury is seen in this patients because this is involvement of the trapezium and also sternocleidomastoid muscle is supplied by the spinal accessory nerve. This is seen with the shoulder drop. This is also your PYT guys. Next, moving on to the Sprengel's deformity, or which is also known as a winging of scapula. This is known as a winging of scapula. Seen with which nerve? This is seen with the long thoracic nerve. The defect is due to long thoracic nerve. Next, this is a test of the Trendelenburg test. For example, the patient is normal. Whenever the patient is following the gait, what happens? You are normally the pelvis which will be having the muscles, right? Gluteus maximus, gluteus medius, gluteus minimus. This is important for the maintain our gait with the pelvis. Pelvic stability will be seen with this muscles, right? So what happens whenever you lift the leg? Obviously, your other side of the pelvic is going to maintain that stability. So what happens if there is a damage to the other side which has to be maintained the stability? If there is a damage, it is going to tilt on the normal side. Okay, it is going to tilt on the normal side. This test is known as a Trendelenburg test. This test is known as a Trendelenburg test. What are the nerves that is involved? If it is a gluteus maximus, this is due to this is due to the nerve that is supplying here, inferior gluteal nerve. Okay, gluteus medius and the gluteus minimus. These both is supplied by the superior gluteal nerve. And if there is a damage to the superior gluteal nerve, so this is the defect that we are going to show. And the test that we perform here is the Trendelenburg test. That is a test that we are going to perform is the Trendelenburg test. Now, neural tube defects. So what is the importance of the neural tube defects? So let's see here. We have the anterior cranial pore and also posterior cranial pore, right? So here you can see this is the picture. This is the anterior and here this is the caudal, which is the posterior side. So anterior, which will be gives rise to the CNS, and the caudal, which will be ends the spinal cord. Okay, these two are important for our CNS system, right? Next, when they are going to close, anterior cranial pores is closed by the 25th intrauterine life, okay, and approximately third week. Next, posterior, which is closed by the 20th intrauterine life on the caudal region, approximately around 4th week, it is going to close. And if there is a defect, if there is a no close, it is going to cause the defect. What are those defects, guys? Highly associated, most commonly anencephaly. It is going to cause the anencephaly. What does mean by the anencephaly? Here you can see the patient is, there is no covering seen with the brain structure because the brain is not fully formed in this patient. And other than that, the patient is also spinal cord defect. If there is a defect in the spinal cord, that means caudal, right? Here you can see this is how the spina bifida, which will be presented in this patient. Okay, and most commonly if it is not closed by the time, it is going to cause the spina bifida. And which is most common overall? Overall is spina bifida, but in the anterior most common is the anencephaly. Anterior is the most common will be anencephaly. And most severe, they will ask what is the most severe. Most severe is seen with the posterior, that is myelomeningocele, that is known as a myelomeningocele in this patients. Next, why this defect is seen? Overall, this is due to folic acid deficiency, because we are going to prevent this with the folic acid only. But most common involvement is multifactorial involvement. Multifactorial inheritance is seen in these conditions. Or the patients, those who are suffering from the seizure disorder, those who are taking the seizure medications, the patients who are associated with the genetic family inheritance, all this will be also contributing to the neural tube defects. So for the folic acid, how much folic acid has to be given for this patient? Normal individuals who want to conceive these patients 1 month prior to, okay, 1 month prior and after 3 months of the pregnancy. After 3 months of the pregnancy, how much we have to give for this patient? 400 micrograms. But there is a history of the neural tube defects. So for this patient, 3 months prior, okay, we have to give the 3 months prior, and also 3 months after. 3 months after, we have to give 4 micrograms has to be given for this patient. But if the mother is having the diabetes mellitus, it is still 400 micrograms. If the mother is having the sickle cell anemia, then you have to give the 5 milligrams that has to be given for these patients. Okay, and for this, the test that we can perform is, the important test is the acetylcholinesterase. Okay, acetylcholinesterase. This is most specific. This is most specific, but the most common is this is the alpha fetoprotein. This is most commonly done, but the specific is acetylcholinesterase. And here you can see these are the defects. Spina bifida, there is an ingrown tuft of hair which will be seen, especially that is covered on the vertebral region. Meningocele, this is like a fluid cyst that is present here. Myelomeningocele, as I said, this is the most severe. Why it is severe? Because it is going to trap the nerves also. Encephalocele is seen in the occiput region, and anencephaly is missing of the part of the brain and the cranial vault, and the schizencephaly is seen with a cleft between the ventricles, that is seen in the schizencephaly. And so if you get that, the why anencephaly patients is normal, okay, because they are missing the part of the brain and the cranial vault, but the brain stem is still normal. That is why these patients will be born as normal individuals. They will be having the breathing, circulation, and also all other organs is present. Only the defect is brain and the cranial wart, but the brain stem is intact, so we can proceed this patient to the organ transplantation. Next, moving on to the action potential. So in the physics, the most frequently asked question, that is the action potential, not just of the IMG or the FMG examination, it can be potential in the NEET PG and INACT also. Action potential have the different phases, guys. Okay, so there is a phase of the phase 1. What is the phase 1? There is a stimulus, and the stimulus must be from our whatever we consume, like sodium, potassium. These are going to be only the most of the stimulus that we are giving for the nerve stimulation. So here you can see it is going to caused by the sodium at the time of the minus 90 voltage. And what we are doing, we are going to increase the voltage by increasing the depolarization. How the depolarization will be occurring? So depolarization will occur in the phase 2. Again, inside the, we are sending inside the plus ions such as sodium influx. So sodium influx will be seen in this patients. So it is going to reach the particular peak that is known as a action potential. And once it is reached the action potential, it has to repolarize back again. This repolarization is seen with the outflux. The outflux is seen with the potassium. Potassium is going to move out. So this is what the repolarization. What is mean by the hyperpolarization? Hyperpolarization means it is a still potassium is moving out, but there is a slow potassium moving out, which is going to cause the hyperpolarization. And next, there is a resting phase. In the resting phase, again we are going to back as a sodium potassium ATP pump that will be formed here in the resting phase. And there is an absolute refractive period. So for example, this is the absolute refractive period. Whole point, this is the absolute refractive period, and this is the relative refractive period. What is the difference between these two periods? In the absolute refractive period, if you give any other stimulus, first stimulus is given, if you give the second stimulus, it is not going to work. But in the relative reflective principle, if you give the second also, it is going to generate back as a stimulus. That is what the absolute refractive period versus the relative or the refractive period. Next, moving on to, this is for the nerve stimulus. Next, we will be moving on to the cardiac. So this is the ventricle bulky muscle, where this is the atria. Atria have no muscle or less muscle that we are going to see. That's why the atria is having the less phases. So here you can see this is the phase 4, this is the 0 phase, and this is the third phase. And here there is an entry of sodium plus calcium. Both are entered here. And after that, again there is a calcium influx which is going to cause the depolarization and the action potential of the atria. And once they reach, they have to cause the repolarization, right? So then they are going to send the, so they will be sending back potassium outside, potassium outflux, right? This is what the atria, which will be consisting of the only fourth phase, 0 phase, and the third phase. Next, ventricles. Ventricles will be consisting of the all four phases. Ventricles will be consisting of the all four phases. So here I given the stimulus with the sodium, and again I have influxed with more and more sodium, which cause the action potential is reached. And here there is a early repolarization, but suddenly there is a calcium influx and the potassium efflux, which will be maintained as a plateau phase in the second phase. And again there is a proper repolarization with the potassium out, proper repolarization with the potassium out. So this is the action potential of the atrium and the ventricle. Okay, this phases has to be remembered. Next, moving on to the muscle contraction. How the muscle contraction is happened? So the muscle contraction is depends on the sarcomere structure. What is the sarcomere? Sarcomere is a functional and the structural unit that we have, that is known as a sarcomere. And these sarcomeres is having the these kind of filaments. One is the actin filament and other one is the myosin filaments. This is going to generate the sarcomere contraction of the muscle. Okay, so how it is going to see? Let's see one by one. For example, what is the structure? The basic structure that you have to take note. Okay, so these are the Z lines. These both are the Z lines. Next, you have here the filaments which is associated attached with the Z lines, and next there is a inside one filament that will be presented. So this is known as a thick filament and this is known as a thin filament. So here you can see this is a thin and this is a thick. So that means myosin which will be in the middle and the actin which will be in the parallel or the perpendicular to each other that we are going to see. Next, there is a line that will be presented. This is known as a M line or we can also call this as a H zone. This zone is known as a H zone. So when we want to relax, they are going to sideline. Okay, they will be relaxed stage. When they are contracting, they will come together. When they are contracting, they will be come together. And how this contraction will be presented in the skeletal muscle. So for example, I have given the stimulus of the action potential. Okay, I have given the stimulus of the action potential. For example, this is the presynaptic cleft. I'm sorry. So this is the presynaptic cleft. Okay, and this is the muscle. And when there is a action potential, it is going to release the calcium inside, right? And the calcium which will be released the acetylcholine, and the acetylcholine which will be turning here, and action potential will influx the sodium, right? This influxing of the sodium again generates the action potential. And here we have the important one, dihydropyridine receptors. Okay, this is the muscle dihydropyridine receptor which is attached with the ryanodine receptor. Okay, ryanodine receptor. So the stimulus, once they generate the or touch the dihydropyrimidine receptor, this will touch the ryanodine receptor and that will influx the calcium. That will influx the calcium. When the calcium is meeting the tropocalcium, when it is meeting the tropocalcium, it is going to generate the contraction of the muscle. It is going to generate the contraction of the muscle. How this contraction is generated? With the help of ATP. With the help of ATP, it is going to generate the contraction. So this is how the muscle contraction is occurring. Next, the questions that can be asked is, when there is a muscle contraction, as I said, Z lines, I bands, A bands, how they are going to change. How they are going to change. This question can be also asked in the examination. During this time, what happens? A band is going to stay intact. A band is the myosin thick band. This is going to stay intact. It is does not change its length. Next, we have the I band. I band is going to become shortens, and the Z line which will becomes closer, and the H zone or the middle zone which will disappear. So these are the changes that you are going to see in the sarcomere during the contraction. Okay. Next, ryanodine receptor. So if there is a high activity of the ryanodine receptor, it is going to cause the malignant hyperthermia. Malignant hyperthermia. So the patient will be having increased blood pressure, increased temperature, increased pulse rate, which will be seen in this patient, and renal failure can progress to this patient, and drug of the choice to treat this condition is the dantrolene sodium. We have to give for this patient. Next, two important graphs that can be asked potential. We are checking here for the sarcomere length and the force. So basically we are checking here the tension of the muscle contraction. So this is the point A, this is the point B, this is the point C, and here this is the point D. So how these forces which will be seen? So if there is a optimal length, okay, if there is a come closer, there is a high tension, okay, at the point of the B and C, here the point of the B and C, there is a maximum tension because of overlapping with each other. Next, at the point of D, there is a minimum tension. Why minimum tension, guys? Because the gap is too much, they are not even overlapping, so there is a minimum tension that we are going to see. And at the point A, there is no tension. There is no tension is seen at the A because there is too much of overlapping which will be seen, that is no tension is seen. This graph is potential to ask in the examination. Next, Rio base versus the chronaxi. What is mean by the Rio base? Rio base means when I give the simply stimulus, the maximum stimulus that I can give for this patient is the Rio base. And when I give this stimulus, it is going to generate that stimulus that is known as a utilization time. This is known as a utilization time. But I increased this to the 2 times. That is the 2 times of the Rio base. But the utilization time is decreased here, and that is known as a chronaxy. Okay, come again. This is the PYQ. What is the DO base? Maximum stimulation. And how much I have stimulated? That is known as a utilization time. When I increase that 2 times, that is going to decrease my utilization time. That is known as a chronaxy. Next topic, that is the oxygen and the hemoglobin graph. Oxygen and the hemoglobin graph, here you can see this is the every time that is a question that is asked, one hemoglobin is going to collect at least 1.34 ml of the O2 which will be carried out. Okay, and this is known as a oxyhemoglobin. This is known as a oxyhemoglobin. So how this shift will be seen? For example, this is the exact point that is going to meet the maximum. Okay, this is the maximum that we are going to see, which is known as a P50. This is known as a P50 at the 25 mmHg. At the 25 mmHg, this curve is known as a sigmoid curve. So if there is a reduced affinity, if the oxygen is not properly meeting the hemoglobin, it is going to shift on the right side. What are the conditions it is going to shift on the right side? Acidosis, 2,3 DPG increased activity, temperature, okay, increased temperature, that is also going to shift to this side. That is what's seen with the right side of the shift. Opposite to that, left side of the shift, if there is a affinity, if it is not properly working again here, that is going to shift to the decreased temperature, decreased H plus ion, carbon monoxide poisoning, and decreased 2,3 DPG that you are going to see. So this is how the oxygen hemoglobin curve and their associated directions will be seen in this picture. Next, here you can see intrapleural pressure, how the differences has been created. So how this intrapleural pressures is important. For example, I say that surface tension will decrease the compliance. Surface tension can decrease the compliance. So surface tension is going to decrease the compliances, right? And the surface tension can cause the collapse. It can cause the collapse. But how can I prevent? I can prevent by surfactant. I can prevent by the surfactant. So surfactant which will be directly proportional. The more the surfactant, more the compliance which will be seen in the patients. More compliances will be seen in this patient. So during the expiration, my lungs will be, the volume of the lungs will be decreased, right? And during the inspiration, my volume will be increased, right? My volume will be decreased. So surfactant will be at this location only. All the surfactant will be conducting at the one point. So the compliance will be high. The high compliance will be seen in this patients. Whereas value is very high, but the compliance is low. Here the compliance is low. Why it is low? Because the surfactant is very far from each other. So my compliances will be decreased this way. That is what the graph depicting of the compliance of the lungs. Okay, this is how we are going to look at here. Next, you can see whenever you are having the expanding forces and the collapsing forces, our chest wall, our lungs are both together can form these compliances. All this has to be maintained to prevent the collapse of the lung. So this is the chest wall compliances, and this is, here you can see this is the lung compliances, and here this is the both compliances that you are going to see. This is the graph that is asked in the previous last year examination. Okay, these points are very important, guys. Next, carbon monoxide and the carbon dioxide. Carbon monoxide is 250 times higher the affinity, and when you mix the carbon dioxide plus hemoglobin, this is known as a carbamino. This is known as a carbamino hemoglobin. Sorry, this is known as a carboxyhemoglobin. Carboxyhemoglobin. Next, this is carbon dioxide plus hemoglobin, known as a carbamino hemoglobin, right? Next, moving on to the sleep cycle. Sleep cycle waves can be asked, guys. So sleep cycle waves can be asked. Here you can see when you are awake, these are the beta waves, and here you can see this is the alpha, theta waves, delta waves, and the REM stage. So alpha waves which will be around 7 to 14 hertz, and N2 stage, these are the theta waves which will be 4 hertz, and the delta waves which is less than 4 hertz, and the REM stage is again the beta waves. How this has to be remembered? So remember with the mnemonic, do the ABG, do the ABG. So delta waves less than 4 Hertz, theta waves 4 to 7 Hertz, right? Theta waves is 4 to 7 Hertz, and next more than 7 Hertz, which will be alpha, and the beta, which will be around 20 Hertz, and 60 plus Hertz, that is seen with the gamma. Okay, and gamma is known as like highly concentrate. For example, now you are reading, this is the 60 Hertz that you are going to see in your brain. That is what this gamma waves, right? This can be remembered. Next, coming back to the sleep cycle, how the sleep cycle is generated. So we have the two different cycles. One is the non-REM stage, one is NREM stage, and other one is the REM stage, right? So we have the two types. NREM stage, which will be N1, N2, N3. REM stage is the paradoxical sleep. Okay, open eye movements will be seen here. You will be having the open eye movements, random eye movements will be seen in this patients, and the whole cycle is around 90 minutes. Whole cycle will be around 90 minutes. In that, 2/3 of the cycle will be the NREM stage, and 1/3 of the cycle will be the REM stage that we are going to have. So let's see. You are awake. So when you are awake, as we discussed, this is going to be the beta waves. Okay, this is going to be the beta waves, and next you are falling into the sleep. So this is the stage 1, N2 stage, and N2 stage is very short, only 25%. And in the N2 phase, if you can observe, you will be having sudden jerks, right? Myoclonic jerks or the hypnic jerks, that is seen with the N2 N1 stage. Next, N2 stage. In the N2 stage you have specifically K complex and also sleep spindles. Okay, these are the burst of the waves that you are going to see. Look at this picture. So this is the K complex and the sleep spindles. So sudden burst of the EEG waves that is seen in this picture. Next, third stage, you are going to have the delta waves, very slow stage of the sleep. This is the delta waves that you are going to see. Followed by this, you are having the REM stage. So REM stage, which will be consisting of the paradoxical sleep. REM stage is a paradoxical sleep, and here there is a spikes which is known as a PGO spikes that you are going to see in this place, and also there is a nocturnal erection which will be seen with the REM stage, and here you are having the nightmares. Okay, and here you will be having the night terrors. Night terrors will be seen in this picture. So this is the sleep cycle, and the condition that you have to remember is a narcolepsy. Why there is a narcolepsy? Decreased orexin, and this is a defect of REM sleep. So the drug of the choice for this patient is the modafinil. The drug of the choice is the modafinil. Modafinil is given for this patient. Narcolepsy patients is having the hypnopic or the hypnogonic hallucinations. Plus, they also having the cataplexy, emotional outburst, that is also seen in this patient. That is known as a narcolepsy. So the patient will be having morning sleep, sudden sleep, emotional breakdowns. That is for the narcolepsy patient. Okay, this is the point that can be asked potentially. Next, moving on to the vitamins and the minerals and their deficiencies. So this is also potential area that we can expect the questions. So first one is the vitamin A deficiency. So here you can see this is the deficiency of the vitamin A. And what is the picture that we are focusing here? These are known as a Bitot spots. These are the Bitot spots. If you don't treat early, that can produce the ulcers. Corneal ulcers will be seen in this patient. Can it involve the skin? Yes, it is definitely involve the skin, and this condition is known as a pyrenoderma, or the follicular dermatitis will be seen in this picture. Next, this patient is suffering from the dermatitis. So which vitamin is going to cause the dermatitis? So this is a classical picture, right? This is known as a K-cell necklace. In which patients you are going to see this K-cell necklace, guys? So those who are suffering from the dementia, dermatitis, and also diarrhea. D, D, D. If you don't read, the patient can die. So this is known as a B3 deficiency or also known as a niacin deficiency. What are the causes in this patient? The patients must be eating the maize, or the patient must be eating the sorghum, or patient must be eating the jowar. All this dietary can increase this condition. Or patient is associated with the B6 deficiency. Genetic condition, heart nerve disease can be seen in this patient. Or patient is having the carcinoid syndrome. Okay, all these are the causes of the niacin deficiency in this patients. Okay, that is the important point that you have to remember. Next, so this is the mammillary bodies, and these mammillary bodies having the ischemia. When the mammillary body is having the ischemia, that is seen with the B1, or we call this as a thiamine deficiency. Thiamine deficiency is associated with the condition Wernicke's encephalopathy. In this, alcoholics, chronic alcoholics will be most of the times they are involved. The condition which will be known as a GOVA, global confusion, the patient will be having the global confusion, and also ophthalmoplegia, right, and ataxia. And if you don't treat early, that can progress to the patients with the Korokov syndrome. Korokov syndrome. And in the Korokov syndrome, you will be having the anterograde amnesia along with the confabulation, which will be seen in this patient. But this is in the alcoholics. Can this seen with the children? Yes, especially those who are taking the polished rice. Okay, polished rice is associated with the B1 deficiency. So this will be presented in the children as a wet berry, or it is presented as a dry berry. Okay, wet berry, wet. This is the cardio, congestive heart failure. Dry berry. This is the neuron. Okay, nerve dysfunction will be seen in this patient. Right, this is the thiamine deficiency. Next, B2 deficiency, riboflavin. Usually this is going to cause the glossitis, cheiliosis, itching, and the burning of the eyes will be seen in this patients. Just cheiliosis, glossitis, remember it could be the B2 deficiency. How you are going to test? B1 deficiency can be tested by the RBC transketolase. B2 is with the help of the glutathione reductase. B6 with the transaminase. B9 with the FIGLO or the histidine load test. B12 with the help of the serum methyl malonate. We are going to look for these patients. Serum methyl malonate that you are going to look in this patients. Okay. Next, another picture that you have to remember, B6. B6 is the pyridoxine. Pyridoxine can be causing the defect. How this is going to be seen? When you are taking of the TB drugs, there is a deficiency with the B6, or the patients who is suffering from the genetic conditions, it can be also seen in this patient. And B6 going to cause the peripheral neuropathy. Even when the deficiency, it is going to cause the neuropathy. Even with the deficiency of the toxicity also, it is going to cause the neuropathy only. Okay, this is what the B6, and it is important for the transamination. This is important for the transamination process. Next, moving on to the another picture that you can see, punctuate hemorrhages, bleeding of the gums, collagen dysfunction. So you can remember this as a scurvy condition. Vitamin C deficiency. Okay, punctuate hemorrhages, gum bleeding, and also abnormalities in the bones and deformities with the collagen defects. That is what's seen with this condition. Okay, this is what the scurvy patients which will be having. Next condition is known as a rickets. The patient is suffering from the rickets. Rickets is associated with a decreased vitamin D. This is seen with a decreased vitamin D. And once the vitamin is decreased, obviously there is a decrease of the mineralization. The patient will be having decreased mineralization. There is no vitamin D, there is no calcium. So once there is a decreased calcium, parathyroid hormone will be increased in this patient, and these parathyroid hormone increase the calcium but decrease the phosphate. So the lab values of the rickets, you are going to see decreased calcium, the increased phosphorate and decreased phosphate that you are going to see. And on the picture that you can see, it is going to cause the widening between the both the carpal bones and also the radius and the ulna. There is a fraying, there is a cupping, there is a splaying. This is going to see in this patient. And the therapy that you are going to give here is the STOS therapy. At least 2 to 4 lakhs units of the vitamin D can be given in this patients. Next, here you can see another picture. What is this condition, guys? Megaloblastic anemia. This is known as a megaloblastic anemia patients. This megaloblastic anemia can be associated with the B12, can be associated with the B9. Okay, two conditions will be seen in this patients. But let's discuss B12 deficiency. So in the B12 deficiency, when you look at the methyl melanoid levels elevated, along with that, it is also going to increase the homocysteine levels. But in the B9, there is a normal methyl malonyl levels, but elevated homocysteine. And here Figlu test is positive, and here Figlu test is negative. B12 is more serious. It can cause the increased, so complete, there is a degeneration seen with the CNS. Okay, seen with the CNS. And the history will be vegans. Mostly these are the vegan patients. Next, B9 condition. B9 we just now discussed, it is going to cause the neural tube defects in the patients. Next, this is the picture of the zinc deficiency, acrodermatitis. This is the acrodermatitis enteropathica. This condition is seen with the acrodermatitis enteropathica. Right? These are the important points that you have to remember. Poor wound healing. Question that is asked: poor wound healing. Antioxidant. If there is a vitamin deficiency, you will be having this condition. Same as the zinc. Zinc is also associated with the poor wound healing in the patients. Poor wound healing will be seen. So these are the basic vitamin deficiencies that you have to remember for the exam. Right? Next, moving on to the another biochemistry topic, that is the amino acids deficiency and the disorders. Discussing with the amino acids conditions, we have the different types of the amino conditions, right? So some are associated with the tyrosinemia. So tyrosinemia are the three types: type 1, type 2 and type 3. Okay, type 2 is most common, and the type 1 is associated with the fumarate acetoacetate deficiency. This is with the acetoacetate deficiency. Tyrosinemia type 2, this is due to deficiency of the tyrosinase transaminase. This is due to tyrosinase transaminase deficiency. Type 3, this is due to PHPP dioxygenase deficiency. And these are also having the other names. For example, type 1 is known as a hepatorenal syndrome. Type 2, this is known as a oculocutaneous type. Type 3 is known as a benign neonatal condition. This is the benign neonatal condition. Alright, next we have the condition that is frequently asking nowadays, that is Zellweger disease. What is a Zellweger disease, guys? This is autosomal dominant PEX gene mutation seen with the very long chain fatty acids. Oxidation was decreased in this patient. Okay, this is decreased. So the condition is associated with the peroxisomes deficiency, or peroxisomes oxidation is decreased in this patient, and it will include cerebral, hepato and renal. All will be included in the patients of the Zellweger condition. Next, we have the maple syrup disease. Maple syrup disease. The maple syrup disease is a branched chain keto acid hydroxylase deficiency, and it includes branched chains. What are the branched chains, guys? Isoleucine, leucine and the valine. All three will be deficiency in this patient. Okay. Next, Ripsum disease. Ripsum disease also the question has been asked. This is due to deficiency of the fentanyl coenzyme, that is deficiency seen with the Ripsum disease. Next, let's see some other conditions that we have here. So this is the condition of the homocystinuria, right? This is the condition of the alkoptinuria, guys. This is the alkoptenuria. And the enzyme that is deficiency in this patient is the homogentisate homogentisate oxidase enzyme. Here you can see this is also known as a black urine disease. And this condition, eyes and the bones and ear lobules, all these are known as a onchronosis. Next, this is the albinism seen with the condition of the tyrosinase enzyme deficiency. Next, this is the picture of the phenylketonuria. So these patients was deficient with the phenylalanine hydroxylase. This is due to phenylalanine hydroxylase deficiency in this patient, right? And this is considered as a most common inborn error of metabolism worldwide statistics, right? And the patient which will be having associated with a musty odor of urine with decreased melanin. That's why here the hair color you can observe in this patient. Along with that, the patient is also having the severe mental retardation. Next condition that you can see, there are the two conditions that I have mentioned here. This is Marfan syndrome. Marfan syndrome is an autosomal dominant condition. Fibrillin 1 gene that is deficiency in this patient or mutated in this patient. Okay, so this patient is type of collagen disease. This is a type of collagen disease, and the lens which will be upper and temporal. Patients will be having mental retardation sometimes and aortic dissection, which will be seen in this patient, and skeletal abnormalities like slender and long bones, which will be seen in this patient. Marfan syndrome. Next, similar to the same features, okay, and this condition is known as a homocystinuria. This is the homocystinuria. It is an autosomal recessive condition, and here cystokinase beta synthase is deficiency in this patient. Cystokinase beta synthase deficiency is seen in this patient, and this patient also tall, slender, and lens in this patient is lower and nasal. Okay, lower and the nasal. This patient will be associated with the atherosclerosis and stroke. This will be seen. And the most differentiating feature is the cyanoid nitroprusside test is positive in the patients of the homocystinuria, and same test cyanide nitroprusside test is negative in the patients of the Marfan syndrome. Next, this condition you all can understand, oil drop cataract. Oil drop cataract seen in the patients of the galactosemia. This is seen in the patients of the galactosemia, and here you can see this is the Leishman syndrome. Leishman syndrome, HGPRT deficiency in this patient, self-mutilation, and the orotic acidurias like orange salts sands which will be seen in the diaper of the patient. Next, moving on to the genetic disorder. So one by one you can recognize their genetic disorders. Okay, so first, autosomal dominant. Autosomal dominant, which will be no skip of the generation. All generations are involved in this patient, and it is associated with the incomplete penetrance, incomplete penetrance which will be seen, and variability of the presentation is also seen. Example, myotonic dystrophy, Marfan syndrome, and also such conditions like whichever is not the enzyme related, all that will be considered as in the conditions of the autosomal dominant conditions. Okay, one of the examples is myotonic dystrophy and also the condition that is Marfan syndrome. Next, autosomal recessive. Autosomal recessive, they will skip the generation. They will skip the generation, and mostly it is a carrier stages, and all the carriers are the homozygous. Okay, homozygous conditions, and here you can see cystic fibrosis, congenital adrenal hyperplasia in this patient, and just now we discussed alkoptenuria, maple syrup disease. All the conditions that will be associated will be enzyme related, which will be seen in the autosomal recessive conditions. Next, X-linked recessive. So for example, she is the female, like mother, she is the carrier, and she will definitely pass to the son with a disease. Okay, so female is a carrier which will transmit to the son. Examples, G6PD. Okay, another example, that is Duchenne muscular dystrophy, G6PD, and also Duchenne muscular dystrophy. Next, X-linked dominant. Here, mostly the fathers which will transmit to the daughters. Okay, which will be transmitting to the daughters. Okay, for example, Rett syndrome, Alport syndrome. These conditions will be X-linked dominant. Next, mitochondrial inheritance. Mitochondria is only passed by the mother. So this is passed by the mother only. Okay, and it will include all children. Whoever she conceive, all children will be associated. Example, Melas syndrome and the NARP syndrome. Melas syndrome and also the NARP syndrome. Next, some of the features that you can see. This is a Down syndrome patient. So the more the maternal age, more the risk of the Down syndrome development in the patients. And what are the features that you are going to see? Simian crease. Like this, the crease will be seen. And also there is a gap between the first and second toes. And from the face, you can see epicanthal folds, facial flat profile, abundant neck skin, mental retardation. This is the most common cause of the mental retardation. And on the congenital heart disease, you can see there is a endocardial cushion defects in this patient, intestinal stenosis, umbilical hernia, and more prone to the predisposition of the leukemia. Overall, the most common is the ALL rather than the AML. For example, less than 3 years, then you have to choose the AML 7. AML 7. Next, Edwards syndrome. This is due to defect of the trisomy 18, and the patients will be associated with the micrognothia, mental retardation, prominent occiput, short neck, congenital heart defects such as VSD in this patient, renal malformations like horseshoe kidney, and also there is a rocker bottom feet that will be seen in this patient. Next, Patau syndrome. This is the 13. Cleft lip and palate, polydactyly, microphthalmia, mental retardation, cardiac defects, umbilical hernia, renal defects with the rocker bottom teeth. Okay, that is in the Patau syndrome. Next, Klinefelter syndrome. This is due to XXY, extra X, okay, 46XXY, and these patients will be having the tall stature, poor beard growth, minor breast development, female pubic hair, and testicular atrophy will be seen in this patient. And the Turner syndrome. This is seen with a short stature, webbed neck, shield chest, and also rudimentary ovaries and the nevus formation that is seen in the Turner syndrome patient. And this condition, this is known as a DiGeorge condition, and DiGeorge condition is due to defect of the third pharyngeal pouch. The pharyngeal pouch condition. And this patient will be having decreased calcium, decreased T cell production, decreased thymus gland, right? So there will be infection, there will be seizures, there will be decreased activity of the thymus gland. That is seen with the DiGeorge syndrome, and DiGeorge syndrome is due to deletion of 22q G chromosome that is deleted in this patient history. Right, this is the completed. Next, oxidative phosphorylation. In the oxidative phosphorylation, they are the complexes, right? So here you can see there are the different types of the complexes, and ultimately they have to produce the ATP, right? They have to produce the ATP, but sometimes this can be blocked by the agents such as any type of the inhibitors. Okay, any type of the inhibitors. Let's see what are those inhibitors. In the inhibitors, we have complex 1, which will be due to biguanides. These are biguanides, and also barbiturates and rotenone poison, and also pyridine poison. Next, class 2, which will be includes of the malonate and carboxyl. And the third one is including of the antimycin, and the fourth one which will be include of the cyanide and also H2S carbon monoxide. Fifth one is going to be the oligomycin. Next, we also have the couplers. Uncouplers will be also seen here. Okay, this can be physiological and this can be pathological. Uncouplers, first and foremost, the most important one, that is the thermogenin. This is the most common. And even increased bile acids can be seen, or increased thyroid gland basal metabolic rate can be seen, increased lipids, like pathological, like patient has took the aspirin tablets. This can also increase the activity of the uncouplers, right? This is the oxidative phosphorylation. In the recent INICT, for example, I use the uncoupler in this patient. What happens? There is a decreased production of the ATP, but increased heat production and increased oxygen demand. When I use the inhibitor, what happens? Inhibitor again decrease the ATP, decrease the heat production, and also decrease the oxidation of that particular thing. So this is the difference between the oxidation of the uncoupler and also inhibitors. Next, moving on to the glycogen storage disorders. The most common one, that is the von Guericke disease, due to deficiency of the glucose 6 phosphatase, and this is associated with the fasting hypoglycemia, lactic acidosis, and marked hepatosplenomegaly. So the patient is having the marked hepatosplenomegaly. Hyperlipidemia, hyperuricemia is seen in this patient, but cirrhosis condition is very less likely and rarely seen in this patient. Next, Pompe disease. Pompe disease is a type of the lysosomal storage disorder, and that is associated with the alpha glucosidase deficiency, Pompe disease. In the Pompe disease, cardiomegaly, cardiovascular congestive heart failure, okay, and this is the early cause of the death in any type of the glycogen storage disorder. Next, Cory's disease. This is a debranching enzyme deficiency, hypoglycemia, hepatomegaly. Remember, like C for Cory, D for debranching enzyme. Next, fourth stage, fourth type, that is Anderson, A for Anderson, B for the branching enzyme. Most commonly hepatosplenomegaly, and it is very early to progress to the cirrhosis in the patient. Next, McArdle's, M for McArdle, M for the muscle phosphorylation. And the patient, for example, suddenly he went to the exercise, muscle cramps, rhabdomyolysis, cola colored urine like this, that is a McArdle's disease. First disease, that is seen with the hepatic phosphorylase, mild fasting hypoglycemia, hepatomegaly, and the cirrhosis is seen in this patient. Next, lysosome storage disorder. Tay-Sachs disease is a hex aminodase A, and this is due to most commonly associated the cherry red spot in the macula in overall all the LSTs. Gaucher's disease, this is the most common overall, and this is due to glucocerebrosidase deficiency. And Ehrenberg-Fask deformity, pancytopenia is seen, and also lipid-laden macrophages crumpled appearance is also seen. Fabry's disease, alpha galactosidase A deficiency, angiokeratomas, corneal dystrophy, and also acroparesthesias will be seen in this patient. Krabbe disease, galactocerebrosidase, and peripheral neuropathy, irritability, and on the biopsy you are going to see this globoid bodies. Niemann-Pick disease, sphingomyelinase deficiency, and it is going to cause the hepatosplenomegaly, cherry red spot also seen. How can you differentiate with the Niemann-Pick and the patient with the Tay-Sachs? Tay-Sachs patients is not going to have the hepatomegaly, whereas Niemann-Pick patients will be having the hepatomegaly. Next, another two condition, Hunter and the Hurler. So remember that Hunter is looking for his X. So this is the only condition which will be X-linked recessive condition. Next, another point that you have to remember, and he is looking for his girlfriend Sulfa. Okay, Hunter is looking with the eyes for the Santa, that is known as a Hunter. So his eyes is normal in this patient. Next, coming to the Hurler. Hurler is opposite to that. The patient is having the mental retardation, cloudy eyeless vision, and this is associated with the mucopolysaccharides type 1, and L-idurodinase is the deficiency in this patients. Next, moving on to the STD diseases. So in the STD diseases, you have to take note what are the types of the STD diseases and how you are going to differentiate them. Okay, how you are going to differentiate them. First, syphilis. How I am going to diagnose the patient with the syphilis? Syphilis will be present as a painless chancre and also painless lymphadenopathy, inguinal lymphadenopathy. Next, Ducre is going to associate with the painful chancroid, painful chancroid plus painful buboes which will be seen in this patient. Do cry. Next, third one, LGV. This is due to chlamydia that the patient has been transmitted with this, and here there is a painless chancroid, primary chancroid, okay, but there is no, there is a lymphadenopathy, but lymphadenopathy is painful. Lymphadenopathy painful. Fourth one, this is the donovenosis donovenosus patient, and here you are going to look like a beefy red appearances which will be seen here, and no buboes or no lymph adenopathy is seen in this patient. This is how you are going to differentiate between the STDs. Next, last but not the least, these are the herpes lesions, very painful, very painful, and the recurrent that will be seen in this patient, right? These are the types of the STD conditions. Next, coming to the drugs, what you are going to give for this patient. This is the penicillin, which can be given for the patient of the syphilis. Do cry. This is a condition of the hemophilus do cry, right? So in the patients of the do cry, we are going to give the azithromycin. This is given for the azithromycin. LGV is the chlamydia. So here I am going to give the doxycycline. And next, donovenosis. Here also we can give chlamydia or doxycycline, or we can go for the azithromycin, and here we can go for the acyclovir. And how about the treatment of the partner? So treatment of the partner has to be given for this all the above patient, right? Next, kits, different types of the kits that we have. Gray color. So this is the gray color is seen with the conditions like urethral discharge, vaginal discharge, painful scrotal swelling patients. Azithromycin and the cefixime is given for this patient. Type 2 green is secedamazole or the fluconazole is about only the vaginal shortage syndrome where you are going to see the candida organism. White one, this is for the genital ulcer disease, especially syphilis patient, and here you can see that this is given for the benzathine penicillin. Type 4 is the doxycycline is given for the non ulcerative grade types of the conditions. Kit 5 is given for the acyclovir, herpes lesions. Kit 6 is for the cefixime, metronidazole is for the lower abdominal pain and the PID. Type 7 is the black doxycycline is given for the LGV prolactins and inguinal tumors. And kit 4 is given for the anorectal discharge for this patient. Tab cefixime is given for this patients. Next topic, vaginal infections, which will be divided into the bacterial vaginosis, trichomoniasis and the candida. So in this, STD is considered as a trichomoniasis condition. So bacterial vaginosis, this is due to Gardnerella vaginalis, and the pH of these patients will be more than 4.5, and the discharge characteristic is it is thin off-white discharge with a fishy odor that is going to be presented. And when we perform the clue cells test under the clue cells of the microscopy, you are going to see the epithelial cells of the bacteria, and also positive whiff test with the KOH is presented here. And the scoring that we give for this patient is the Nugent scoring. Nugent scoring is given for this patient. Drug of the choice is the metronidazole. Moving on to the trichomoniasis. Trichomoniasis will show thin yellow green frothy and the malodorous discharge will be shown in this patient. Under the microscopy, you are going to see the motile trichomoniasis with the flagella, and the drug of the choice is metronidazole, and you should also treat the sexual partner. Next, candidiasis. It is going to show the cheese kind of thick whitish color cottage cheese discharge will be seen with the pruritus. The patient will be having the pruritus or itching, severe itching will be seen, which is uncharacteristic from the trichomoniasis and the bacterial vaginosis. And under the microscopy, you are going to see the pseudo hyphae, and it is going to be the acidic environment. Less than 4.5 is going to be presented as the pH, and the drug of the choice is the fluconazole. And another two conditions, pelvic inflammatory condition and the genital TB. Genital TB is most commonly seen in the virgin females, and this is going to be most common presentation of the patient is infertility. Infertility is the common presentation of this patient. And what is the cause of this infertility? Bilateral corneal block. Bilateral corneal block. And coming to the pelvic inflammatory disease, this is most commonly associated with the sexual transmitted only now. So this is not a direct STD, but multiple sexual partners is one of the conditions for the pelvic inflammatory disease, right? This is due to multiple sexual partners, and it will be including the uterus, it will be including the tubes, it will be including the ovaries. All inflammation, female reproductive system will be involved in this patient. Okay, so this is how you are going to differentiate between these all female reproductive conditions. Next, moving on to the alcohol use disorder. Alcohol use disorders is considered as one of the serious considerable disorder worldwide. It is almost 80% plus population is burdened by the alcohol use disorder. Let's see how the alcohol is metabolized in our body. When you intake of the alcohol or the ethanol formation, how it is going to be converted? It is converted with the help of the aldehyde dehydrogenase, and it is going to form these aldehydes. And these aldehydes, when they go into the circulation, especially in the small intestine of the GIT, it is going to be have the maximum absorption. It is going to have the maximum absorption which will be seen in the small intestine because it's of the wide area of the small intestine. Okay, next, coming on to the blood alcohol concentration. Blood alcohol concentration more than 30, which will be positive for the alcohol, and more than 200 is going to be the serious, the patient can have the coma. Blood alcohol concentration. Next, another important point that you have to take note that the serious effects from the alcohol over the time use, just now we discussed that Wernicke's encephalopathy and also Korokov syndrome, right? These two syndromes will be presented in this patient. What we discussed here, global confusion, ophthalmoplegia, and also ataxia symptoms will be seen in this patient. And if it is progressed, this is going to be the chronic, this is going to be the acute. And Korokov syndrome, confabulation, and also anterograde amnesia will be seen in this patient. And here it will be involving of the mammillary bodies. So this will be involving of the mammillary bodies, and it will include the thalami nuclei. It will be including of the thalami nuclei and also hippocampus because of the memory involvement. So how we are going to treat these two conditions? We have to treat that. First of all, you have to give the IV thiamine. This question is asked, followed by you can give any other drugs, that you can give glucose also. But the first and foremost is the IV thiamine should be given for this patient. Next, if the patient is having the withdrawal symptoms. So withdrawal symptoms is also one of the most serious conditions, right? So first, the patient is going to have the tremors. Okay, it could be fine tremors that will be presented in this patient. At what point? At the time of 6 hours. Okay, at the time of the after the last drink from the 6 hours, the patient will be having this condition. Next, hallucinations. Next, the patient can have the auditory hallucinations. This will be presented as a auditory hallucinations, right? And this will be around 12 hours. Let's say this is around 12 hours, less than 12 hours. Next, moving on to the first GTCS, the generalized tonic-clonic seizure of the first episode, which will be exactly, it is around 24 hours after the last drink of the withdrawal by the patient. Next, this is a serious condition that is known as a delirium tremens, right? Severe tremens, and the patient with the visual hallucinations. Visual hallucinations will be seen in this patient. Severe delirium conditions features, and also continuous tremors will be seen. And this is after 48 hours of the last drink of the patient. So this is the generalized timeline of the withdrawal of the patient who are presented with the withdrawal of the alcohol. And how we are going to treat this patient? When the GTCS, here the drug of the choice for this patient is the benzodiazepines, go for the lorazepam. Okay, go for the lorazepam. And here also the treatment will be benzodiazepines only. The lorazepam is given, which is good for the liver condition, because the other benzodiazepines can be not having that much good, but this drug can be good for the patient. So this is the delirium tremens treatment. Next, another point of view that you have to take note is how we are going to treat this patient in the long term. So in the long term, we can treat this patient with the drugs which can be given as a anti-craving and also deterrent agents. Okay, anti-craving and the deterrent agent. Anti-craving agents, one of examples is the acromepostate. This drug can be given for the patient. And the deterrent agent, that is the disulfiram. that is the disulfiram drug can be given for this patient. This is the alcohol dehydrogenase inhibitor. So this is the alcohol dehydrogenase inhibitors, right? This is how we are going to treat the on the long term basis of the patient. And what is the methanol poisoning? Okay, methanol poisoning is this adulterated, this is the adulterated alcohol only. Okay, and it is going to happen with the Hooch tragedy. The patient can have the Hooch tragedy and the severe seizures which can be associated with the coma and even death to the patient, right? Illegal illicit drug, this can be seen. And here the treatment for this patient is ethanol. Most of the times we can give the ethanol which will balance this one, and if not we can go for the fomepizole. The antidote will be fomepizole for this poisoning. This is how we are going to treat these conditions, right? Next, another point that I wanted to tell you is how the smoking can be cessation. Okay, how the smoking cessation is done for this patient. For the smoking cessation, over the time, the drugs will be motivation. First therapy is the motivation, then followed by the drug that we see here, busulfiram, and followed by the varnicicline. This drug is the best drug, or we can give with the gums, lozenges, right? This can be given for this patient, but at least 15 minutes prior you should have the care that no hot liquids before you take, because the it can decrease the chances of the absorption of this particular gums and lozenges. Okay, so these are the smoking cessation drugs. Next, sexual perversion. Sexual perversion, easy question, one can be asked in the examination. So first one is the exhibitionism. So exhibitionism, so those perverts who is expose the genitalias, expose the genitalias in the public place, and this is crime according to the Indian law. Next, other one is the forturism. Forturism is kind of rubbing the genitals in public place to strangers. Okay, and this is also considered as a uh, crime in the India. Next, voyeurism. Okay, this is like known as a peeping tom who look into others' private life. Okay, others' private life, and this is also considered as a crime in the public place. Next, we also have the necrophagia. Necrophagia means, guys, remember that necro is a dead. So necrophagia is means eating the corpse, eating the corpse. And necrophilia, necrophilia, this is known as a eat uh, having sexual intercourse, sexual intercourse with the corpse, and these both also considered as a crime in India. Okay, these are the crimes that is most commonly considered. Next, masochism versus the sadism. So masochism versus the sadism is, masochism is known as who receive the pain. Okay, who receives the pain voluntarily. Sadism is one they show the pain to other person. They show pain to partner. Okay, next, another conditions, transvertism. Transvertism means, okay, this is like dressing opposite gender, dressing like opposite gender, that is seen with this condition. Next, fetishism. Fetishism is inanimate objects is used for the sexual gratification. Okay, these are the types of the sexual perversion that is previously asked in the examination. Next, hypersensitivity reactions. So type 1, which will be IgE related hypersensitivity, okay, and it is going to release the degranulation. These IgE allergens will be triggered in the patients, and the conditions are like systemic anaphylaxis, seasonal allergies, allergic rhinitis, hay fever, food allergy, and hives, and urticaria, and also eczema conditions. Next, type 2, this is the IgG antibody mediated cytotoxic hypersensitivity. And most of the all the blood product conditions, like if you take hemolytic anemia and also thrombocytopenia and blood related, blood transfusion related, and rheumatic fever, all these conditions whichever related to the transfusion and the blood, all are considered under the type 2 hypersensitivity reaction. Type 2 hypersensitivity reaction. Other than that, antibodies, for example, Graves disease, this is also due to antibodies. Myasthenia gravis, antibodies which will be attacking. And good pasture syndrome, this is also due to antibodies, right? Pemphigus vulgaris or the Pemphigus foliaceus, the desmoglein attack, this is also due to hypersensitivity reaction. Next, type 3 is seen with the immune complex, not just the antigen and also antibody, both will be attacking here. Examples such as glomerulonephritis, rheumatoid arthritis, and the systemic lupus nephritis. And also post streptococcal glomerulonephritis will be also seen here, that is the glomerulonephritis. Next, cell mediated hypersensitivity reaction. This is most commonly seen with the contact dermatitis, tuberculin test, and also autoimmune diseases such as diabetes mellitus type 1, multiple sclerosis, and the rheumatoid arthritis. Okay, these are some of the examples for the hypersensitivity reaction. Next, moving on to the another important point, acute inflammation. In the acute inflammation, the one thing that you have to remember is that whenever the cell is going under the reversible injury, means some there is a stress that is causing in this patient. What is the most common reversible injury in this patient is the hypoxia. And if hypoxia is affected, the most common one will be affected is the neurons. This question is asked previously. Next, when there is a reversible reaction, what happens in the patient? So the first one will be the cellular swelling. Okay, this is the swelling which will be seen in this patient, followed by the blebbing. Due to that swelling only there will be a blebbing. So this is a pure reversible condition, the patient can be come back to the normal state. But once there is a irreversible stage, there is no reversibility of the patient. So what happens in the patients of the reversibility? There will be mitochondrial permeability, so it can damage the mitochondria. Lysosomal rupture will be seen in this patient, and complete nuclear. And also, if you can see, this is the plasma membrane which is also going to damage in this patient. So this is the irreversible condition. This is the irreversible conditions. On the electron microscope, when you look at the irreversible changes, it is going to show the amorphous. This will be showing of the amorphous fluctuant densities. This is purely due to calcium deposits after the death of that particular cell. This question is also asked. Next, how the patient will be having the inflammation. In the acute inflammation, we say that acute inflammation is the sudden, right? It is a sudden action, and it is going to have the neutrophils. Immune system will be involvement in this patient, right? And how this presentation will be start. For example, whenever you have the injury, the first event will be vascular events. Okay, first events will be vascular event. So in this vascular events, there will be early vasoconstriction. There will be early vasoconstriction, and followed by that there will be vasodilation, and then followed by the vascular permeability. This vascular permeability is the highlight of the whole acute inflammation. This is considered as a hallmark of the condition. This is considered as a hallmark of the condition, followed by the rolling, okay, rolling, pavementing, and adhesion, and immigration, diapedesis, which is also known as a diapedesis, to the spot where the inflammation is causative organism is presented. Then it will release the chemotaxis. These chemotaxis which will be going to kill by the help of the phagocytosis. Okay, it could be mostly free radical injury by enzyme. Any other enzymes also can be participated here. So first and most important part is the vascular permeability. There is a hallmark of this particular thing. And next, adhesion. Adhesions is done by integrin, and diabetes is done by the PE glycam. It is done, and rolling and the pavementing which will be done by the other factors like Cialis, Lewis factor, selectins, all will be done by other types. But this is the events. This order is asked in the examination. Look at here. Once there is a organism has presented with this some inflammation. So what happens? Our most of the W cells which will be going to rolling, with the help of the selectins, E-selectin and the P-selectin. And after that, they will be joined at one point to the endothelium. Once they are indicated, this is going to release the PE cam. This is what the diaperesis event, and it will reach the particular spot where the inflammation is happening. And from here, it is going to chemotaxis, and that will kill the phagocytosis of that particular enzyme. Right? Next, moving on to the another important point, that is the diuretics. Okay, diuretics is also frequently asked questions, guys. Let's see one by one what are the diuretics. So, carbonic anhydrase inhibitors. So, image based questions. So, proximal convoluted tubule. This is the carbonic anhydrase inhibitors. Next, this is the descending loop. Here we have the drugs which is known as a osmotic diuretics and thick ascending loop of Henle. This is going to involve the loop diuretics. DCT, it is going to involve the thiazides. And next, the collecting tubules which will be involving of the potassium sparing agents. Okay, this is going to involve the potassium sparing agents. Let's understand one by one. Carbonic anhydrase inhibitors, the enzyme which prevent the converting of the carbonic anhydrase. Okay, so this is going to be the block the conversion of the enzyme. And the drug that we use in this patient is the acetozolamide. Right, acetozolamide is the common drug we use. And what are the indications of the using of the acetozolamide? High altitude. So this can be used for the patients of the high altitude, and whoever is suffering from the metabolic alkalosis patient, metabolic alkalosis, respiratory alkalosis, we can use this drug. And also glaucoma conditions, right? Especially the closure glaucoma patients, we can use this one, right? Next, what are the side effects? Side effects can be asked examination. We are using in the alkalosis, and the drug name itself acetozolamide. So this is going to cause the metabolic acidosis in the body, and it is acting in the PCT. So PCT can produce the stones in the patients. The stones can be seen in this patient, and it can damage the RTA. Tubular, the necrosis can be seen. RTA effect is seen in this patient, and also it can cause the sulfa allergy, and the patients who are cirrhosis. So the liver cirrhosis, it is contraindicated as it can increase the ammonia in the body. So this is contraindicated. Next, osmotics. So the best drugs of the osmotics is the mannitol. Mannitol is given for the patients of the increased intracranial pressure, and most of the trauma patients. End stage renal disease can be given for this patient, and also those who are having the dialysis, the condition dialysis disequilibrium. Dialysis disequilibrium condition also we can give this patient. Okay. Next, what are the side effects of this patient? It can show the patient can have increased fluid in heart. So that's why this is contraindicated in the heart failure patient. Along with that, it can also have the electrolyte imbalance. Electrolyte imbalance is seen with this patient. Next one, loop diuretics. The common drug is furosemide, and the mechanism of action of the furosemide is sodium, potassium and the chloride. All will be going to blocked in the thick ascending loop of Henle. And where it is given, guys? This is given in the patients of the hypertension, pulmonary edema, which is congestive heart failure. It is given in this patients also we can give this one, and also those who are suffering from the CKD, which patients also we can give, and the edema patients also we can give this drug. What are the side effects? Side effects will be loop lose everything. So that means calcium, magnesium, sodium, potassium, chloride and the potassium, everything will be decreased in this patient. Along with that, increased glucose, okay, increased uric acid levels, and also increased lipids, and increase the metabolic alkalosis, which will be seen with the loop diuretics. Opposite to that, thiazides, not opposite, it is quite same only. The one of the drug is a chlorthalidone, and here the mechanism of action is the sodium and the chloride is blocked in this patient. It is going to be inhibited. And the patients where we give, hypertension patients we can give, edema patients we can give, and the renal failure patients also we can give, but end stage renal disease is again contraindications. And the patients those who are suffering from the nephrogenic diabetes insipidus we can give, Patients with the hypertension with the osteoporosis, this patient also we can give this drug. And what are the side effects, guys? Side effects, it is not like a side effects, but it will maintain the calcium levels. Okay, it is decreasing, loop diuretics is decreasing, but the thiazides is going to maintain that calcium levels, but decrease the sodium, decrease the potassium, and decrease the chloride, which will be seen again, and increase the glucose, increase the uric acid levels, and also it will increase the lipid levels and increase the metabolic alkalosis of the patient. Okay, these are the common side effects which will be seen with the thiazides. And last but not the least, we have the potassium sparing agents. Potassium sparing agents, the drug is spironolactone. Okay, and the uses of the spironolactone is Conn's syndrome and resistant hypertension we can give for this patient, resistant hypertension, and also ascites, which is related to the cirrhosis. And side effects is gynecomastia. Side effects are gynecomastia, and potassium is sparing. It can cause the arrhythmias in the patients, right? Hyperkalemia can trigger the arrhythmia in this patient, and this can act also on the androgens. Okay, this is going to act on the mineralocorticoids receptors, right? It can also cause the impotence in the patient. So these are the side effects of the different types of the diuretics questions. Next, oral hypoglycemic drugs, we have the classification bigonides. That is, the drug of the choice is the metformin, and this is the drug of the choice for the diabetes mellitus patient, and it will decrease the glucose hepatic production, gluconeogenesis. It will increase the insulin sensitivity, and it will also decrease the LDL over the time, but it has the specific side effects, which is the B12 deficiency, lactic acidosis, and the GI upset. And key note that you have to remember is, if it is a less than 200, less than 30, this is considered as a contraindicated of the patient. Next, sulfonylureas, glyburide, glimepiride, glipizide. This is a drug, and it is going to block the potassium channel so that the insulin secretion will be increased in the beta cells. But it is a very potent hypoglycemia. Weight gain is also associated. So that is why it is contraindicated in the patients of the heart disease. Next, meglitinides is the same condition, but it has a short acting comparing to the sulfonylureas. Next, DPP-4 inhibitors, sitagliptin, saxagliptin, or the linagliptin. This linagliptin is safe in the renal failure patient, and it is also show the weight loss. But how the DPP-4 is acting? It is inhibit the DPP-4 enzyme so that the incretin levels will be increased in the patient, and associated side effects will be nasopharyngitis, headache, and the pancreatitis rarely. And the GLP-1 agonist. GLP-1 agonist is also going to increase the incretin. This is one of the best drugs we consider in the hyperglycemia patients. Okay, and it is associated with nausea, weight loss, pancreatitis. So this is the way famous drug you might have heard, Ozempic drug, that is the semaglutide subcutaneous drug. And next, dual GIP and the GLP-1 agonist is present, that is the tirzepatide. Next, SGLT2 inhibitors, canagliflozins or the empagliflozins. This is going to inhibit the renal glucose reabsorption. So obviously when you inhibit the renal absorption, what happens? There is a more and more urinary glucose will be seen in this patient, but prone to UTI and the general genital infections will be seen. Dehydration can cause, and the diabetes ketoacidosis will be seen in this patient. Best in the heart failure patients, and weight loss is also seen. Amylin analogs, the drug name is the pramlintide. This is a subcutaneous drug. It can be given for the type 1 patients and the type 2 patients, and the thing is that it is going to suppress the gastric emptying, and so that the glucagon levels will be decreased in the body. Nausea, hypoglycemia is the common symptoms. And alpha glucosidase, acaribos, miglitol, or the vaglibos, the drugs are, and it will delay the intestinal carbohydrate reabsorption. Flatulence, diarrhea, abdominal pain are the side effects, and should not be given in the patients of the Crohn's disease, liver failure, or the renal failure patients. And the last drug, that is the thiazolidinediones. This is the pioglitazone or the rosiglitazone drug. It will increase the insulin secretions. How it is going to increase? PPAR gamma enzyme it is going to increase with the help of the GLUT4, and this is associated with the weight gain. So, but this is one of the renal safe drugs that we can use for the patients, but it is associated with the fracture, bladder cancer, heart failure risk. These are the some of the important drugs. Next, statins. Statins question can be asked. So one of the best drug that we use is the statins. Most commonly overall the world, statins are used. And how it is going to act, guys? Hmge CoA reductase. This is the inhibition of the statins action, and it will decrease the LDL, VLDL, and also triglycerides. And the best benefit is it will increase the HDL. And the statins also have the antioxidant property, anti-lipid property, and also it is going to be anti-platelet aggregate property and also anti-inflammatory property. This is known as a pleomorphic property of the statins, but it is associated with the side effect of the hepatotoxicity and severe myopathy that is seen in this patient. So that's why we don't give in the patients of the pregnancy and the children, which can be highly toxic for this patient. Next, fibrates. Fibrates are gemfibrozil or the fenofibrate. This is acted by the PPR gamma. It will uh, indirectly it is going to decrease the VLDL and also triglyceride clearance from the body. It will increase the HDL also. Same condition, fibrates can associate with the myopathy or the gallstones in the patient. Bile acid analogs. Bile acid analogs, which will be seen as a cholestyramine or the cholestyramine or the cholesterol. So the drug which will be related to the chole, remember those are the bile acid binding resins. And how it is going to increase? It will be increasing with the help of the enterohepatic duration, and it will also increase the conversion of the cholesterol to the bile acids. So indirectly it will decrease the LDL levels in the body. It will be associated with the GI upset, triglycerides, which will be clearance will be seen in this patient, and absorption of the fat soluble vitamins which will be decreased, and it is completely safe in the pregnancy and the kids patients because it is just acting by the enterohepatic circulation. Niacin, the drug is going to block the hormone sensitive lipase enzyme, and it will decrease the hepatic VLDL synthesis, decrease the LDL and increase the HDL. It is associated with the hyperglycemia, hepatotoxicity, hyperuricemia and the flushing. PCSK9 inhibitors. PCSK9 inhibitors, the drug name is the evolocumab. The drug name is evolocumab, and which degrades the LDL receptors and increase the LDL receptor by decreasing the LDL conversion in the body. And injection site reactions, myalgias, neurocognitive effects, which will be seen as the side effects. Next, antiarrhythmic drugs, we have the class 1 sodium channel inhibitors, but at the same time the class 1A block the sodium and block the potassium. That's why we are going to see the increased QT interval. What are the side effects? Increased QT interval can progress to the torsades de pointes or SLE like syndrome, synchronism will be seen in this patients. 1B, which will be acting on the sodium blockade, but it is no effect shown on the potassium. So potassium is open in the patients of the 1B. And side effects is confusion, tremors, seizures, cardiovascular depression, malignant hyperthermia will be also seen. Examples are lidocaine and the mexlizine. And 1C drugs, this is a strong sodium blockage which will be seen in this patient, and it is considered as a pro-arrhythmia drug. One of the example is the propafenone or the flecainide drugs. Class 2 is the beta blockers, metoprolol, esmolol, atenolol. It will decrease the SA node and the AV node conductivity so that the PR interval will be increased in this patient. Bradycardia, AV block, bronchospasm, impotence and the hypoglycemia are the side effects. Class 3, potassium channel blockers. What we discussed, potassium can block. If it is a block, it is going to cause the QT interval blockade. And the drugs are the amiodarone, sotalol of the ebutyroid. It can increase the chance of the torsades de pointes, maximum with the ebutyroid and minimum with the amiodarone. Class 4, calcium channel blockers, verapamil and the diltiazem. And this is known as a drugs which can be given for the patients of the alternative conditions such as asthma patients. We can give this, and it will also increase the PR interval. Constipation, bradycardia, AV block, gingival hyperplasia, edema will be seen in this patient. Next, one drug that you have to take note, that is the amiodarone. What is the mechanism of the amiodarone? Amiodarone is a condition which will be having the mechanism not only on the sodium, it will be also acting on the potassium, calcium and all the important these elements which will be acting in the heart. Okay, that is the effect of the amiodarone. So this is the most accepted anti-arrhythmic drug that we use for the patient, right? And whenever we use the amiodarone, this is associated with the side effects. So these side effects which will be including of the pulmonary fibrosis. Remember, it can cause the pulmonary fibrosis and deranged LFTs which will be seen in this patient. Mostly hypo, then the hyperthyroidism which will be seen. Why the thyroidism seen? Amiodarone ion is present, iodine is present in this patient, that is going to cause the hypothyroidism. And ceruloderma means blue color discolorization of the body will be seen in this patient. And corneal oral like deposits is also seen in this patient. These are one of the side effects are important. Anti-glycoma drugs, prostaglandin analogs. The drug of the choice is the latinoprost, given for the acute angle open glaucoma. right? This is given for the acute angle open glaucoma patients, and it will increase the uveoscleral outflow of the aqueous humor. But the side effects are iris pigmentation, eyelash growth, conjunctival hyperemia, uveitis, and the cystoid macular edema. And also we have the beta blockers. The drug of the choice is the timolol. It is a topical beta blocker. It will decrease the humor, aqueous humor production. And bradycardia, blepharoconjunctivitis B, blockage of the nasolacrimal duct, and bronchospasm, corneal anesthesia C. All the B, C side effects will be seen in this patient. Alpha 2 agonist. It will also decrease the aqueous production and increase the trabecular outflow. Dry mouth, drowsiness, depression, apnea, eyelid retraction, follicular conjunctivitis, and don't give the children because of the cause of the apnea in this patient, especially brimonidine, because it is going to cross the blood-brain barrier. Carbonic anhydrase, we just now discussed topical drugs, dorzolamide or the brinzolamide, or you can also go for the acetazolamide. It will decrease the aqueous humor of the patient. Paresthesia, GI upset, kidney stones, and the metabolic acidosis. Cholinergic agents, that is, we have the pilocarpine. It is going to cause the meiosis of the patient. Constriction will be seen in this patient. Trabecular outflow will be increased. Brow ache, eyebrow ache will be seen, meiosis, and retinal detachment also detrimental side effects. Rho kinase inhibitor, the drug that we use, that is a netrasodil. It is going to cause a corneal verticillata. That is the question that has been asked. Next, moving on to the milestones, pediatric milestones, which is one of the most important topics. So the first one is the gross motor. Remember that it is going to follow the cephalocaudal pathway. Gross motor will be following the cephalocaudal pathway. At least remember these. 3 months of the age, neck holding will be seen. 6 months of the age, the patient will be sitting in the tripod posture, sit with it with the support. 8 months, which will be sit without support, crawling is started. Remember CRA, and this one is CRE. So creeping is the second word, crawling is the first word, right? A is the first word. So crawling will come first and the creeping will be come next time. And 10 months, the patient can stand with support. 12 months stand without support and walk with support, and 15 months patient can walk without support also seen. 18 months running will be seen. 3 years rides the tricycle. 4 years the patient will be climbing the 1 foot at a step and downstairs, and also patient will be hopping. This is the milestones of the gross motor system. Next, fine motor. Fine motor using of the hands at one particular postures. 4 months we are going to see the bidextrous grasp. 6 months unidextrous grasp. 8 months there is a palmar grasp, which is known as a radial and mature type. 9 months immature pincer grasp, and 12 months mature pincer grasp we are going to see. And 2 years the patient can draw the line. For example, here you can see draw the line. 3 years the patient can make the circle. 4 years the patient can make the cross. 4.5 years draw the squares, 4 ends. 5 years triangle, and 6 years diamond. Whatever I have marked, that question can be asked in the examination. Okay, language milestones. 3 months cuckoo, and 6 months monosyllables, 9 months bisyllables, 18 months 8 to 10 words, and the 3 years recognizes the patient name, age, gender. 3 words, and 4 years patient can tell the story, and rhyming also done. Social milestones. 3 months patient can recognize the mother, 2 months social smile, and 6 months stranger anxiety, 9 months waves bye bye or the peekaboo, or the 1 year patient can play the simple play game, and 4 years patient can also have the group play. Right, these are the milestones that has been asked. Next, coming to the malnutrition. Malnutrition is important. The patient who is suffering from the malnutrition, which will be associated with the weight loss or any other features. But the WHO has given the criteria. According to the WHO criteria, the patient should have the edema, nutrition related edema. This is due to nutrition, not because of the cardiogenic or any other condition. It is solely related to the edema only. Next, mid upper arm circumferences, which is less than 11.5 centimeters, another prerequisite to diagnose the patient with the malnutrition. Next, weight for height. Weight for height is less than -3 standard deviation. This is also present. Any one of the following is present with edema. Any one of the following with edema, that is considered this patient as a SAM patient, severe acute malnutrition patient. What are the features? Let's see. Marasmus patient or the Kwashiorkor patient. Kwashiorkor patients is extremely, these patients are extremely associated with the protein deficiency. These patients are protein deficiency, and these patients are protein deficient plus calorie deficient. Let's see the features of this patient. First and foremost, the patient is having the edema and prominent moon-like faces, fatty liver, protuberant abdomen, dry and peeling skin. These are the Kwashiorkor features. Marasmus patients, if you can observe severely, the patient is so lean, you can visibly see in the bones, right? Disproportionate head size is seen, sparse hair is seen in this patient, muscle wasting, right? All this will be seen in these conditions. Next, the marasmus is compensated. So this is a less severe. So body will compensate over the time. But the protein is decompensated. So this is a severe condition. It can progress to the heart failure and patient can die. Right? So this is presented with the edema. That is a distinguishing feature. And here there is no edema is presented. And this patient is more alert, and this patient are having the apathy, no interest at all. Next, the patient appetite, voracious appetite. If you give the food now, the patient is having highly hunger. But as I said, apathy here, no appetite is seen in this patient. Most and most severe is the this condition only. And here you can see this is the hair. Hair will be associated with the flag sign. And next, dermatitis is known as a flaky paint dermatitis, which will be seen in this patient. How we are going to treat this patient? So treatment is hospitalization. You have to add the patient to the hospitalization and prevent the complication. Prevent the complication. How you are going to prevent the complication? You have to choose the stabilization phase. Stabilization phase, which will be around 2 weeks, followed by that maintenance phase. Followed by the maintenance phase. This is around another 3 to 4 weeks. We are going to choose this patient. And important points is we can give the patient Rasmol. This is a highly maintained or the given, and F75 to F100 meals is given. All the micronutrients will be given for this patient. Antibiotics prophylaxis and also IV fluids. IV fluids is given for this patient. Next, moving on to the neonatal resuscitation. This question has been asked previously, right? First of all, whenever you see after immediately birth, the baby is not having the breathing, what can be done immediately? So you have to check the patient term. Is the baby is term or not? Is the baby is preterm? Or the baby tone is present or the hypotonia? Baby patient is crying or not? Okay, these are the three things that you have to check. If anything is not present, then go for the term gestation or anything. If you check, if it is something is abnormal, please start the warm and maintain the normal respiration in this patient. Okay, and how you are going to do? Warm, dry and the stimulate. Stimulation should be done on the soles of the baby, and even that is not clearing, check the heart rate of the baby. If it is less than 100 beats per minute, what you have to give? You have to start the patient 15 seconds after. If you still find that the patient is not having the less than 100 only presented, then we have to start for the patients of the immediate. The patient has to be treated with the positive pressure ventilation. The patient has to be treated with the positive pressure ventilation. Despite of that, still if it is not working, the heart rate is going even below less than 60 per minute, then we have to consider for the compressions. Chest compressions can be done for this patient. ET intubation can be also done. And still if it is not controlling, then we have to go for the IV epinephrine that has to be given for this patient. And the question that is asked, what is a golden minute? So we can save the patient immediately. So from the time of the birth to starting of the positive pressure ventilation, this is considered as a golden 1 minute of the time of the patient. Okay, golden 1 minute of the patient that we have to see. And what is the ventilation that is given for this patient? At the time of the 1 minute, it is 60%. At the time of the 3 minutes, it is a 70% of the SpO2. 5 minutes, it is a 80%. After 10 minutes, you will reach the 95% that we are going to see. Okay, so let's see once again, guys, how we are going to treat this patient. For example, the baby is born. Immediately, the baby is not having cry. Something tone is abnormal. You have to stimulate the baby, suction if needed, and then check the heart rate. less than 100 beats per minute. Start the patient with the PPV. Positive pressure ventilation has to be started. And we said that this is the golden 1 minute. Right? This is the golden 1 minute. Okay. Despite it is not controlling, then still heart rate is less than 100. Then you have to start the patient. Intubation can be done, or we can also go for the chest compressions. Still there is no improvement, even it is deteriorated less than 60 per minute. Then you have to consider the IV or umbilical vein epinephrine has to be given for this patient. Okay, this is another 30 seconds and this is also another 30 seconds. So okay, within the 2 to 2.5 minutes you have to start considering the patient. Okay, this is how we are going to do the neonatal resuscitation. Next, IMNCI guidelines. In the IMNCI guidelines, we are first going to see the pneumonia. So, green means normal, guys. So, there is no pneumonia. Yellow, patient is having the pneumonia. And here, this is the severe pneumonia. This patient is having the severe pneumonia. Next, how the patients are presented. General cough, right? Cold, fever. These are the symptoms. And in the patients of the pneumonia, they will be having the fast breathing or the chest drawing, but SpO2 is normal. And here SpO2 is abnormal, plus the patient is having the danger signs, more prominent chest indrawing is seen for this patient, right? How you are going to treat this patient? Treatment for the first no pneumonia patient, you can send home and supportive treatment for this patient. Next, second category patient, here you have to give the oral antibiotics and tell the patient to follow up within the 3 days. Immediately that has to be treated by this patient. Next, severe pneumonia, you have to start the patient on the IV antibiotics, oxygen therapy if needed, and shift the patient to the higher center. That has to be done immediately. This is the first dose we give at our PHC only. Next, another IMNCI guidelines, that is known as a dehydration. Here, no dehydration. And this one, some moderate, let's say moderate or some dehydration. And here it is severe dehydration. Sometimes it can cause the hypovolemia shock of the patient. No dehydration. So basically the patient with normal cry and also no signs of the lethargy, okay, no sunken eyeballs, all this will be considered as a no dehydration. Next, moderate dehydration, patient are irritable, patient is thirsty, and patient is restlessness, that will be seen. Sunken eyeballs, which will be also seen in this patient. Next, severe patient, here you are going to see the lethargy, thirst is not present. So this is a severe feature. If the thirst is not present, the patient can land in the severe condition, and urine output is completely decreased, right? All these are the signs of the shock, hypovolemia shock. And how you are going to treat? Here the treatment is breastfeeding can continue the mother, and other fluids in the home, rice water or any other fluids can be given for the baby. And importantly, ORS can be also given for the baby. Next, rehydration for the type 2. Type 2, I mean pneumonia, yellow category, we have to give the rehydration. How you are going to rehydration? For every episode, you have to replace with the ORS at 75 ml per day. 75 ml per kg, 75 per ml per kg in 4 hours. That has to be given for this patient. And also you can give other one, be breastfeeding is given and fluids can be also given. Breastfeeding can be continued in this patient. Next, coming to the severe condition, and here only IV fluids. You have to start the patient on the IV fluids, and ORS is still continued, but the breastfeeding is stopped for a few seconds because it can cause the aspiration. Okay, and maintenance fluid is also given for this patient. Maintenance fluids is also given, and around 100 ml per kg you are going to give. Maintenance fluids are done by the help of the holiday cigar method. Next, what is the ORS? What is the ORS formulation? ORS will work by help of the SGLT2. In the kidney, it is going to work by the SGLT2 with the help of, for example, sodium and the glucose. Both are consisting of the 75 ml, 75, and this is also 75. Potassium chloride, which will be consisting of the 65, and the citrate, which will be 20%. A citrate will be consisting of the 20%. So this is the features of the ORS that will be presented formulation. It is going to replace the fluid, ongoing fluid loss. Cataracts. Snowflake cataract is seen in the diabetes type 1 mellitus, and traumatic cataract is a rosette shaped cataract, posterior subscapular, post-trauma, nuclear cataract, and Morgaggian cataract, and intumescent cataract. All these are the same only. Okay, nuclear, Morgaggian, and the intumescent. And cortical cataract. This is belongs to the senile age. Okay, and the patient is having the peripheral vision loss, and nuclear cataract is having the central vision loss. Central vision loss that you are going to see in this patient. Okay, and Morgaggian is the patient which will be with a hypermature. This is known as a hypermature, and intumescent is the mature type of the cataract. Next, other types. Metabolic cataract. This is like a sunflower cataract seen with the Wilson's disease. Christmas tree, myotonic dystrophy, posterior subscapular. Oil drop cataract, posterior subscapular, seen with the galactosemia. Next, another some of them, blue dot cataract is seen with the patients of the Down syndrome. Okay, this is seen with the Down syndrome. Lamellar cataract seen with the infantile type, and shield cataract is seen with the patients of the dermatitis, atopic dermatitis. These patients will be having the shield cataract. And which rays is going to cause the cataract? Gamma rays or infrared rays. This is going to cause the cataract. Okay, these are some of the important named cataracts that you have to remember. Next, moving on to the squint. So before the squint, you have to understand what is the mechanism of action. So we have the three nerves: third cranial nerve, fourth cranial nerve, and the sixth cranial nerve. Right? This is the oculomotor, trochlear, and the abducens nerve. So cranial nerve 3 is going to supply all the muscles. It is going to supply all muscles except LR6 SO4. Superior oblique is supplied by the fourth cranial nerve, and lateral rectus is supplied by the sixth cranial nerve. Next, what are the mechanism of action? Superior rectus is going to cause the elevation, inferior rectus is going to cause the depression, medial rectus is going to cause the adduction, and lateral rectus is going to show the abduction. Superior oblique is opposite, it is going to cause the depression. Inferior oblique is going to cause the elevation. Okay, these are the mechanism of action, main mechanism of action. So all are connected to the common tendinous ring, except all are connected at one point only, except inferior oblique muscle. Inferior oblique is not attached here. Next, how you are going to see this mechanism of action? You tell the patient to do these movements. Tell the patient to look into the medial nasal side, or tell the patient to look at to the opposite side, that is the lateral side, LR6, and also depression downside, superior oblique and inferior rectus is working, and above that inferior rectus and the superior oblique is working. Sorry, inferior oblique and the superior rectus, for the elevation it is working. So this is how we are going to check the patients with the eye movements, right? These are the eye movements that we are going to check. And cranial nerve palsy can be seen, right? So for example, let's say that the patient is presented with the oculomotor 3 palsy. What we discussed, all the muscles are supplied by the oculomotor nerves. So the patient will be included medial rectus, inferior rectus and the superior rectus, and also inferior oblique and levator palpebral muscle, which will be eyelid, and ciliary constrictor muscles also seen with this patient. So they will be having all kind of symptoms. For example, the patient is having the ptosis, pupillary dilatation, and down and outside is seen for this patient. Why down and outside? Because in this patient the lateral rectus is still normal, because lateral rectus is supplied by the LR6. This is supplied by the sixth cranial now. So the patient will be looking the downward and outward. Why patient is looking the outward, downward? Because of SO4 is also normal. So that's why the patient is looking the out and down side. Next, trochleomotor. Trochleomotor, it is going to only block the superior oblique muscle. So the patient, when they are having the problem with the depression, so the patient will be having the extorsion and downward gaze, that is going to see in this patient. The rotational diplopia, and it will worsens when patient is looking down and towards the nose. And abducens now, this is going to involve the lateral rectus. So the patient can't do the eye movement to the lateral side. So the patient will be having the mid dilated or the lateral gaze palsy. Only the patient will be having the medial side, horizontal diplopia, and gaze is affected to the side. So these are the three different nerve features that has been asked in the examination. Next, as we said, we are going to discuss the overview of the complete important points about the vitamin A deficiency. So vitamin A deficiency is seen most commonly with the nutritional. So the patient who is having the nutritional causes, they are going to have this condition. Okay, that is a vitamin A deficiency. Next, another point that you have to remember, this is going to be the most common cause for the blindness. This is going to be the most common cause for the blindness in the children with the formation of the vitamin A deficiency. And what is this feature, guys? This is known as a Bitot spot. Bitot spot that we are going to see in this patient. So how the patient is presented? The most common symptom, this is the corneal ulcer. Let's see the images first. This is the follicular dermatitis or pyrenoderma. So let's see the features first. Most common symptom. The patient will be telling us about the corneal xerosis, conjunctival xerosis, dryness. Patient is going to tell us about the dryness and night blindness. Next, sign. The most common sign will be Bitot spot. The patient will be having the Bitot spot. And we have the categories. ZN, this is for the night blindness. Z1A, this is for the conjunctival xerosis, dryness of the conjunctiva. X1B, this is for the Bitot spot. Okay, and X2, this is for the feature of the corneal xerosis, cornea became the dry. And Z3A, the ulcer is formed but less than 1/3 of the thickness. X3B, it is more than 1/3 of ulceration that is seen. So the patient is going into the keratomalacia. And XS, patient is having the scarring, cornea is went into the scarring. This is can cause a increased loss of vision is seen in this patient. And if it is progressed to the fundus, it is going to be irreversible condition. How you are going to treat this patient? You are going to give the drug on the day 1 and also day 10 and day 14 of vitamin A is given for this patient. How much is the dosage? Depends on the patient age. Less than 6 months, it is going to be 50k international units. More than 6 months but less than 1 year, then 1 lakh international units. More than 1 year to 5 years, we are going to give the 2 lakhs international units. This is how we are going to give for this patient. But the patient is more than 1 year but 8 kgs only. So in this scenario, we still give the 1 lakh international units. Why? Because vitamin A can cause the toxicity. So low weight can cause the toxicity in this patient. So that's why we are going to give the 1 lakh international units only. Next, moving on to the biosafety levels. Okay, biosafety levels. This question can be asked, guys. First one is the human wastage. Human waste. Next, the drugs like cytotoxic drugs or petri dishes, laboratory dishes we will be throwing here only. Next, vomit or any fluids, bodily fluids that can be thrown. Okay, so it is like a spoiled clothes, vomit or the feces or any other fluids discharge will be thrown here. These are the spoiled cloths. Next, empty blood bag with infection. With infection, empty blood bag is thrown in the yellow color. Next, cotton and also gauze. Next, coming to here, gloves, all the plastic, for example, IV sets, urine bag, okay, sometimes blood bags. Most commonly, the blood bags is also it's a quite controversial. This is also here. Foley's catheter, Ryle's tube, or the OGT, right, oral gastro tube, and all the catheters, central venous catheters, all will be also thrown here only. Next, blue color is mostly for the glass, metals, right, screws, and empty vials, ampoules, right, empty vials, ampoules, that is so thrown here in the blue color. And white color is mostly metals, which is considered as a sharps, okay, not another metals by sharps, or blades, scalpel, needles, right, fixed syringe. Fixed syringe is also thrown in the white color one. Next, food adulteration. This condition is known as a neurolathyrism. This is the neurolathyrism patient. And these neurolathyrism patients, are having the spastic paralysis. This patient is having the spastic paralysis, involvement of upper motor neuron nerves. Why this has happened? Because of consumption of adulterated food such as kesari dal. Why this is adulterated? With the chemical of bio, the BAU chemical is involved in this patients, and that is going to cause the damage to the upper motor neuron. Like this, the patient will be involved in the patients of the neurolathyrism. And how can we prevent? With the help of the vitamin C, we can give for this patient and ban the crop that has to be done for this patient. Next, moving on to the, here you can see this is a fungus, and this growth is known as a aflatoxins. This growth is known as a aflatoxins. So the patient is associated with the hepatocellular carcinoma. Next, this is the endemic ascites. So patient is not having ascites due to the alcohol, but this is more of the endemic ascites. Okay, the seeds they have are the Cortalaria seeds, and these seeds is consisting of the pyrrolizidine. Pyrrolizidine chemical is present, is going to cause the ascites in the patient. Next, these are known as the ergots alkaloids. Here you can see these are the ergots, and these are highly vasospastic, and that can cause the gangrene. Next one, here you can see these are the seeds, Junjunia seeds. Okay, Junjunia seeds. This is going to cause the epidemic dropsy. Epidemic dropsy. What is meant by the dropsy, guys? The patient is having the edema, congestive heart failure, pulmonary edema, and also ascites. All features will be seen in this patient. What does this Zunzunia seeds is having the chemical? It is consisting of the sanguine. It is consisting of the sanguine. This is the food adulteration. Questions can be expected in the examination. Next, moving on to the demography features. Right, this graph can be asked. Let's see one by one. What are the phases? We have the 5 phases. Phase 1, phase 2, and phase 3, and also phase 4, phase 5. Right, phase 5. So in the phase 1, this is the high stationary. Phase 2 is early expanding, and phase 3 is late expanding, sorry, late low stationary. This is the low stationary. Come again, guys. So 1 is high stationary, 2 is early expanding, 3 is late expanding, fourth is the low stationary, and fifth stage is the declining phase. So in the first phase, the birth rate is high, same as the death rate is high. And early expanding, the birth rate starts to fall. This is the slow phase. Okay. And here you can see this is the feature. The birth rate is starts to fall here. Next, death rate is also going to fall. This is in the second phase, right? The death phase is also starts to fall, but birth rate is still remains the stable. Next, late expanding. In the late expanding, the birth rate is declining, death rate is also declining. Okay. Next, low stationary. Birth rate even further decrease, death rate is also further decreased. Death rate is also further decreased in this patient. Declining phase, it keep on declining, keep on declining. So these are the features of the different types of the features. But what is important here? So this is known as a trap. Why it is a trap? Because the birth rate is still stable. If the country is continued in this phase, it can cause the severe economic crisis in the patients. Okay, that is what the trap. And there is a maximum gap also seen between the death rate and the birth rate in the second phase. And third phase is seen with the India. Fourth phase is seen with the USA, America, and last phase is a negative. Last phase is a negative, and highly the patient is having the economy boost or the economy gifts that is present in the fourth, followed by the second. Sorry, followed by the third type. That is what these three important points that you have to remember in the demography. All right. In the demography, you should also know about some of the definitions. For example, total fertility rate, general fertility rate, okay, and net reproductive rate. These are the questions that can be asked in the examination, right? Let's see one by one. Total fertility rate. This means the woman number of children that the women have had with reproductive age 15 to 49 years plus age specific rate of the fertility that is also present. This is a total fertility rate. General fertility rate is just considered number of number of children at the reproductive age. That's it. Simple definition, general fertility rate. Net reproductive rate. Net reproductive rate is the female had the daughters, right? So these daughters age specificity plus the morbidity, okay, age specific and also age specific to the death, that is also seen with the net reproductive rate. And general reproductive rate, this is known as number of daughters that the female have had at reproductive age, number of children, generalized for general fertility rate, and here it is only daughters. Okay, there is a difference. These questions can be asked. Next, bone metabolic disorders. So in the bone metabolic disorders, you can see here they are the conditions such as osteoarthritis and the rheumatoid arthritis, right? These two conditions is presented here, osteoarthritis and the rheumatoid arthritis. Osteoarthritis is known as a degenerative condition. Rheumatoid arthritis is an autoimmune or inflammatory condition, and this is highly age specific, more than 50 years, and here it is also age specific, females more commonly than the males, associated with less than 40 years. Okay, one feature. And here there is a ESR or the CRP, inflammatory markers will be normal, and here ESR CRP which will be elevated, rheumatoid factor which will be positive, anti-CCP is also positive in this patient. One point, right? And coming to the features, this will be involving of the MCP joints is involved in this patient. Okay, MCP joint, sorry. Here the most importantly it will include the dip joints, and here it will include the MCP joints, right, most commonly, and it will spare the MCP and it will spare the DIP will be decreased, and the pain will be increased with the work, and here pain will be decreased with the work, and external features like other conditions is less common, but this is associated with the more with the other, for example nodules, other systemic uveitis, autoimmune other conditions is also seen in this patient, and treatment for this patient is the NSAIDs, and here also we are going to give for the patient of the NSAIDs and DMARDs. We can also go for the hip replacement surgery. Let's see the features of the this X-ray. We are going to see the osteophytes, bone growth will be seen. In the early, you are going to see the sclerosis, gap between the joints. This is also seen. Okay. Next here, you are going to see same pannus formation. Gap will be seen, but sclerosis is not seen in this patient. Next, complications. Complications are Heber-Den nodes, and also Bouchard's nodes. Okay, Heber-Den nodes and the Bouchard's nodes. Heber-Den nodes and the Bouchard nodes. Heber-Den nodes is involvement of the HD. Remember HD, involvement of the dip joints. Okay, this will be involvement of the dip joints. Next, B, Bouchard's nodes. This will be involvement of the BP. Remember like BP. Sorry guys. Remember like BP. This is pip joints. That is seen. This is the one. And here Z deformity is seen. And also swan neck deformity. Okay. And Botaniers deformity, which will be seen in this patient. Next, continuing with the other condition, that is the osteoporosis. This is the condition of the osteoporosis. Most commonly, this patient was decreased with the bone mineral density. Right, this is due to bone mineral density. What are the most common causes? Menopause. Post-menopause patients that will be having the most common. Right, they will be affected more, and females are more affected than the males. And also other like habits like smoking, sedentary lifestyle, alcohol, and those who use the drugs like thyroid medications can cause this one, because bone metabolic density was decreased here, and heparin or anticoagulant drugs, steroids can cause. Okay, these are the drug related osteoporosis, and also cocaine, all this will be causing the osteoporosis. Next, what is the test that we are going to do? We discussed in the radiology, DEXA scan is the most common done, and this is considered as a best investigation of the choice. If it is less than -2.5, this is considered as a osteoporosis of the patient. What is the drug of the choice for this patient? Bisphosphonates. And what is the mechanism of the bisphosphonates? Mechanism of the bisphosphonates is it is going to decrease the osteoclast activity. So bone resorption was decreased, and side effects, it can cause the atypical fractures. Atypical fractures can be associated with this one. Next, ankylosing spondylitis. This is an seronegative condition. This is a seronegative condition, most commonly seen with the males than the females. HLA-B27 is positive in this patient, usually young adults involved in this patient, and it will increase the sacroiliitis. Is a basic feature most commonly affected in this patient, right? One thing, and these patients, pain will be decreased by the work. So pain will be decreased by the work with the same feature that you are seeing in the rheumatoid arthritis also, right? And in these patients there is a pain plus extra feature like extra organal features. What are those extra organal features? Most commonly patient will be associated with the uveitis. Okay, uveitis can be seen in these conditions. Next, what is the test that we can do? So test we can do is the HLA testing we can do, and also in the physical examination you can do the Scober's test. Scober test, we ask the patient to bend. When they're bending or the flexing forward, so that length will be decreased because of the sacro and the ilium fibrosis. Here you can see this is the fusion and this is the bones that is going to cause the fuse. Next, drug of the choice is NSAIDs as a first line of the therapy. Next, moving on to the bone tumors. So in the bone tumors, as we discussed, what is the most common benign tumor? Most common true benign tumor. If they ask what is the most common benign tumor, osteoid osteoma. Osteoid osteoma. Next, most common true malignancy. This is the osteosarcoma. Most common overall is the metastasis. More with the prostate comparing to the breast. If you don't see the metastasis, then go with the multiple myeloma. Next, moving on to the points, osteochondroma or the exostosis. This is the most common benign tumor. Okay, this is the true benign tumor, guys. True benign tumor is the osteoid osteoma. Only the benign tumor, then osteochondroma. It will include the metaphysis, and malignant transformation can cause the chondrosarcoma. Osteoid osteoma. This is a true benign tumor. Decrease the pain by the NSAIDs, and here you can see this is a nidus formation. Less than 2 centimeters nidus formation is seen in the diaphysis. Enchondroma, 20 to 40 years, involves the small bones. You can see here associated with the Maffucci syndrome or the Olial syndrome, and most common benign bone tumor of the small bones of the hands and feet. Giant cell tumor or the osteoclastoma, eggshell crackling, soap bubble appearances, involves the distal femurs, and we have to treat with extended curettage and also adjuvant therapy. It can progress to the metastasis also. Next, osteosarcoma involves the metaphysis, sunburst or the Codman's appearance. Here you can see this is a sunburst, Codman's triangle, most common primary malignant bone tumor and most radio resistant tumor also. Ewing sarcoma, onion skin appearances on the X-ray, involvement of the diaphysis, and this will be associated with the translocation of the 11 and 12. And next, chondrosarcoma involves the pelvis, femur, shoulder, rings and calcification is seen, cartilage tumor resistant to the chemotherapy. Fibrous dysplasia involves the femur, Shepherd's crook deformity, here like this, Shepherd's crook deformity, and bone tissue is replaced by the fibrous tissue. On biopsy, you can see in the Chinese letter appearances. Multiple myeloma, most common malignant bone tumor, punched out lytic lesions will be seen, involvement of the vertebrae, skull, and the pelvis of the patient. Next, schizophrenia. In the schizophrenia, you have to take note about the what are the schizophrenia good factors and the bad factors, good prognosis and the bad prognosis. We all know that schizophrenia is associated with the positive symptoms and the negative symptoms. Positive symptoms includes the hallucinations, delusions, and the disorganized behavior, right? Disorganized behavior. Next, negative symptoms, apathy, avolition, okay, flattening of effect, that will be seen in the second phase, that is the negative symptoms. So good prognosis, if ever the patient is female, good prognosis, and the patient is having the chronic incident, chronic presentation, those who are in the young individuals which will be also old individuals, old age, okay, with mood disorders, okay, other disorder like mood disorders is better. Family history is not present, birth trauma is not present in this patient, and only positive symptoms is present. All are good prognosis. Bad prognosis, males, acute incidents, young individuals with the history of the schizophrenia previously, family history like mother or father, someone is suffering from this condition previously, and birth trauma is present, and negative symptoms present. So all this will be considered as a bad prognosis of the patient. Okay, next. So we are going to give the drugs, right? How we are going to give the treatment for this patient? We are going to use the atypical versus the typical drugs. The typical drugs are known as a first generation. This is the second generation. First generation D2 blockers, and here D2 plus serotonin blockers. D2 blockers and the serotonin blockers. And this is highly associated with the extrapyramidal symptoms, less extrapyramidal symptoms. Low metabolic symptoms. This is highly associated with the metabolic symptoms. Okay, these are the features. Next, how we are going to treat this extrapyramidal symptoms, how they are presented. So first one, acute dystonia. This is the muscular rigidity, oculogycular crisis, torticollis, painful head tilt is seen in this patient. This is less than hours to days, and for this patient we can give the drug of the choice benzexol. Benzexol is given for this patient. Next, akathisia is like days symptom. Suddenly the patient is having the tapping, compulsive restlessness. These are seen in this patient. Drug of the choice is beta blockers. Okay, drug of the choice is beta blocker. And tardive dyskinesia, this is the last year PYQ. What happens? This is a chronic condition. Almost it will take years to months. Months to years. It will be seen. Involuntary mouth movement, like rabbit kind of mouth movement will be seen in this patient. Drug of the choice is valbenazine is given for this patient. Okay, valbenazine is given. Repetitive tongue protrusion, lips smacking, finger-like involuntary movements is seen with the tardive dyskinesia. And tardive dyskinesia, you can also discontinue D2 blockers and shift to the atypical. Next, another condition, drug-induced Parkinsonism, mask-like expression, shuffling joint, and pill rolling tremors. And here the treatment is benzexol. Next, here comes the serious condition, that is the malignant hyperthermia. In the malignant hyperthermia, tremors, tachycardia, diaphoresis, autonomic instability, hypertension, clonus, hyperreflexia, all this will be seen. This is known as a malignant hyperthermia, and for this patient, the drug of the choice is dantrolene. Okay, dantrolene is given. So these are the extrapyramidal symptoms, right? Their treatment. Next, coming to the other conditions like hyperprolactinemia. Hyperprolactinemia is due to drugs such as risperidone, highly with the risperidone, and also haloperidol. Simply you can withdraw the drug to treat this one. Next, we also have the clozapine. Clozapine is a very best drug, guys. It is going to have the resistant schizophrenia patients also we can give this drug. Clozapine has the features like sialorrhea, agranulocytosis. This is a serious condition, agranulocytosis, and also severely myocarditis and increased risk of lipids and metabolic syndrome, seizures also seen. Okay, this is the clozapine. Olanzapine, this is the second generation, right? Olanzapine is having the highly metabolic features. Comparing to the clozapine, it is even more with the olanzapine. And there is zero effects, zero metabolic, which will be seen with the Z for 0, Z for ziprisidone. This drug has zero metabolic effect. Next, coming to the quetiapine. Quetiapine is going to cause the cataract. Right? These are the some of the side effects that you have to remember. Next, coming to the depression. What are the definitions of the depression? The major depression disorder is more than or equal to 2 weeks. Mania, or we can say this is a bipolar 1. This is more than 1 week. Hypomania, this is the hypomania which is more than 4 days. Okay, this is a bipolar 2. And cyclothymia. Cyclothymia is more than 2 years with mania. Dysthymia, dysthymia is more than 2 years of mild depression. Okay, next, double depression. What is the double depression? Double depression is the dysthymia dysthymia is converted as a major depression disorder. Next, we also have the atypical depression. Atypical depression. Atypical depression, generally the patients are having a low mood. So this patient will have the low mood but high appetite, high appetite and high sleep cycle. That will be seen with the atypical depression. So these are the common definitions we can expect in the examination. Okay, next, in that the depression, the treatment is very important. So we have the SSRIs, right? These are the serotonin inhibitors blocker. Next, SNRIs, right? Serotonin and the norepinephrine, that is blocked here. So first, SSRIs, what is blocked here? 5-HT serotonin uptake is blocked in this patient, and here serotonin plus norepinephrine is blocked in this patient. When you are blocking the reuptake, your just reuptake is blocking, but this concentration is increased, right? Concentration in the circulation is increased, because depression patients, that is decreased. That is we are going to see in this condition. Next, side effects. Side effects are, you are going to see the delay the ejaculation. Delay the ejaculation. D for delay ejaculation, D for dupoxetine. So these dupoxetine drug have the highly delay ejaculation, and it can be used for the premature ejaculation patient. Right? Treatment can be given as a premature relaxation. Next, it can cause the serotonin syndrome. So what is the serotonin syndrome? Come back to here. So this is the serotonin syndrome. So the patient is presented with the serotonin syndrome. Increased serotonin levels. This can be associated with the hyperreflexia, increased bowel habits like diarrhea, agitation, diaphoresis, tachycardia and autonomic instability, which will be seen in the patients of the serotonin syndrome. Okay. Next, SNRIs. SNRIs is associated with the side effects of the hypertension crisis. Hypertension crisis will be seen in this patient. Next, coming to the atypical agents. Atypical agents, these are most severe drugs, actually higher the toxicity which will be associated with this patients. Toxicity, remember TCA drugs. TCA drugs are more toxicity in this patient. Okay, that is one of the drugs that you have to remember. Next, we have the lithium, right? Lithium is the one drug which we use for the patients of the bipolar. But lithium has a narrow therapeutic index. It is having the narrow therapeutic index. So highly toxic. So what are the features of the toxicity? Basically nausea, vomiting, which will be seen in the patient. And also patient is associated with the diarrhea, right? Renal failure can be seen in this patient. So dialysis is required. So tremors, decreased thyroid levels. Okay. And over the time, the patient can also develop the nephrogenic diabetes insipidus, which will be seen in this patient. If the mother is taking, this can cause the Ebstein's anomaly, box shaped heart, which will be seen. For the nephrogenic diabetes insipidus, drug of the choice is amyloid, because thiazides can worsen the condition of the lithium. Next, thanatology. So thanatology is study of the death. So here you can see we are looking at the algar mortis. What is the algar mortis, guys? Cooling of the body. Okay, post death there is a cooling of the body. Almost 0.4 degrees Celsius per hour, the dead body is going to get cool. Okay. Next, rigor mortis. Rigor mortis is due to ATP depletion. This is due to ATP depletion, and it is going to follow the rule of 12. So it will start around 12 hours, then it will peak the 12 hours at the maximum, and then followed by the 12 hours relaxation. That is what the rigor mortis, and it will follow Nystein's rule. Okay, these 2 points are important. Next, postmortem lividity. Postmortem lividity or the segregation, or you can also call the liver mortis, and this will start around early, around 30 minutes, and it will fix by the 6 hours, and it will end by lost by 10 hours. Okay, discolorization on the dependent areas. Next, cadaveric spasm. Cadaveric spasm is a different type. So this cadaveric spasm is the antemortem finding. This is the antemortem finding associated with the drowning. Okay. Next, putrefaction is the early decomposition. This is due to microbial. And what is the microbial that is involved? Clostridium welchii is the one which will be involved in this patient. Okay, that is a Clostridium welchii. Color changes, gas formation, tissue softening, which will be seen in the patient. Marbling is the arborization pattern. You are going to see the marbling of the superficial vein. All this will be seen in this patient. Why this is seen? The superficial vessels, because of the sulfa hemoglobin. Because of the sulfa hemoglobin. Adipocere, also known as a saponification, waxy tissue and conversion of the body fats into the soapy and the waxy type. Adipocere means involving of the adipocytes. Mummification. This is completely drying and the dehydration of the body. That is seen with the mummification. Okay, these are the important points that you have to give. And mummification is around 1 year time. It will take 1 year time. And marbling will take around 36 hours. Marbling will take around 36 hours, right? These are the important points that you have to remember. Next, toxicology. In the toxicology, the questions can be expected by the antidotes. Okay, arsenic which will be resembling of the cholera. Same like cholera presentation will be seen. And for this patient, you are going to give the British antigen, or you can also give the DUMSA. Next, for the patient of the mercury, okay, mercury, the bony deformities will be seen, right? DMCA drug is given for this patient. Cadmium, also given DMSA. Copper patients, we can give the penicillinase. Penicillinase is given for the copper. Next, lead is given with the EDTA. Okay. Next, phosphorus. Phosphorus has to be treated with the, again, DUMSA is given for this patient. Next, carbon monoxide is given oxygen therapy. Paracetamol, N-acetylcysteine, best drug is given. Opioids is given with the naloxone. OP poisoning is given with the atropine plus paralidoxine. But carbamate poisoning, same like a OP poisoning, but atropine is enough for this patient. What if we have atropine poison itself? So then you have to give the physostigmine. Physostigmine is given for this patient. Iron, increased iron, desferoxime is given for this patient. Okay, that is the one drug. Cyanide patients. Cyanide patients, you can give the B12. Hydroxy B12 is given, and also amyl nitrate is given for this patient. Okay, that is also given for this patient. Methanol poisoning we already discussed. You can give the ethanol, and if ethanol is not present, formipizole is given for this patient. Okay, benzodiazepines, benzodiazepine drugs. In the benzodiazepine drugs, flumazenil. Whatever the barbiturates, for the barbiturates you can give the alkaline diuresis. Beta blockers is going to be given with the IV glucagon. IV glucagon is given for this patient. Datura poisoning or the belladonna poisoning, we can give the atropine for this patient. Okay, atropine is given for this patient. These are the some of the drugs that you have to remember. Next, coming to the pneumoconiosis, silica is going to cause the silicosis, right? And these silicosis will be increasing of the upper lobe deformity. Fibrosis can be seen. On the X-ray, you are going to see the popcorn calcification or eggshell calcification, which will be seen, and it will increase the risk of TB and increase the risk of cancer. Silicosis, this is the most common. And next one is the asbestosis. Asbestosis is due to asbestos dust drug, but it is highly associated with the lower lobe pathologies, and it can risk of the mesothelioma. Specifically, it is a mesothelioma, but commonly it is going to involve the risk of the bronchogenic cancer. Bronchogenic adenocarcinoma is seen. Anthracosis, this is due to coal dust. It is not going to have the risk with the TB or the cancer. only it is going to cause the fibrosis over the time and involves the upper lobe, okay. Next, bagosis. Bagosis is due to sugarcane, okay, sugarcane, it is due to sugarcane. And dysnosis is due to cotton, and berylosis is due to beryllium. Okay, these are the some of the pneumoconiosis and their condition. Direct question can be expected, guys. Next, moving on to the lung tumors. Let's see the general features of the three different lung tumors, and the fourth one is the exception. If you don't see any of these features, obviously that is the fourth type of the condition, right? So, squamous cell carcinoma, this is most commonly associated with the females. Small cell carcinoma, again males is more common. Adenocarcinoma is females is more common. Nowadays, the most common is the adenocarcinoma. Okay, this is showing the higher incidence. And the patients here is association with the smokers, and here also smoker, but here there is a non-smoker. Involvement of the lobes, it will be central lesion, central lung, and here also central lung, and this is the periphery. This is the periphery. Okay. Next, gene involvement. P53 gene is involved in this patient, and this is associated with the genetic mutations, especially LMIC. This is associated with the LMIC gene, and here it is involvement of the EGFR2 involvement of the gene, that is also seen here, and ALK gene is involved, okay, in the adenocarcinoma. And paraneoplastic syndromes, increased calcium levels, increased chances of the SIADH syndrome, and here also it is due to calcemia or migratory thrombophlebitis for this patient. Next, markers, involvement of the markers. P63 is positive, P40 is positive, and here it is the chromogranin is positive, and synaptophysin and bombesin is positive for this patient because it is a neuroendocrine tumor. Okay. Next, in this patient it is going to positive for the TTF and the napsin positivity. On the histopathology, if you see the keratin pulse like this is the keratin pulse that you are going to see, that is seen with the patients of the squamous cell carcinoma. Adenocarcinoma is most commonly seen with the lipidic pattern. It is going to see like this lipidic pattern, which will be seen, and azupardic pattern seen with the squamous cell carcinoma, azupardic calcification. Okay. Next, moving on to the facial palsy. Before that, how the facial nerve is divided. So it has the different types of the curves that is seen with the facial nerve. So this is a sensory root that we are getting the facial nerve, and when it is divided behind to the petrous bone, it is going to give rise to the greater petrosal nerve, and this greater petrosal nerve is going to important for the spingopalatine fossa, right, pterygo canal, that is going to be supplied by the greater petrosal nerve. And for the stapedius muscle, it is going to give the small nerve, that is for the stapedial nerve, and the chordae tympani, this is given for the tongue supply. T for tympani, T for taste, it is going to have the sensation, and after the post auricular nerve, it is going to give the branches, facial branches is given for the patient, right. Next, how the patient palsy is seen. For example, if it is a lower motor neuron, so the damage will be at the branches here any of this branch is damaged, this is going to cause a lower motor neuron palsy. And in the lower motor neuron, for example, the lesion is on this side, obviously the lesion will be on the same side, so we are going to have the ipsilateral facial damage will be seen. Okay, upper motor and lower motor, all the muscles will be involved ipsilateral. Even forehead is also going to involved in this patient. Whereas upper motor neuron, the damage is above the division. So like this, for example here, so this is going to show the bifurcation, right? So the patient will be having on the contralateral. So contralateral side is affected in this patient, and even contralateral also half face is only involved. Forehead is spared. This is how you are going to differentiate. Next, head trauma. epidural hematoma and the subdural hematoma. Epidural hematoma is most commonly associated with the collection blood between the cranium and the dura mater, and 70% is trauma cases only. Artery that is involved, middle meningeal artery. And how the patient is presented? With the help with this biconvex lens is presented. What is the treatment? Craniotomy is done for this patient. Okay, craniotomy or the burr hole has to be done. Next, subdural hematoma. These are due to bridging veins, venous discharge, and this is the shape, sickle shape you are going to see in this patient, crescent shape or the moon shape that you are going to see, and here also craniotomy is the treatment. Okay, the artery involvement is important. Next, subarachnoid hemorrhage. Subarachnoid hemorrhage is associated with the berry aneurysm, and berry aneurysm rupture. You are going to see this kind of picture. Okay, hyper intensity and the brightness is seen around the circle of Willis. Okay, that is a presentation, and patient will be having thunderclamp headache that is going to be presented. Okay, this is how we are going to differentiate of the head trauma condition. Next, collagen. Collagens are the four types. Type 1 is seen with the bone and tendons. Type 2 is seen with the cartilage. Type 3 is seen with the blood vessels and the skin. Type 4 is seen with the basement membrane of the condition. They are the two defects. If it is a type 1 defect seen with the osteogenesis imperfecta, bone fragility, multiple fractures, blue sclera and the hearing loss. Ehlers-Danlos syndrome, this is the type 4 or 3 or type 5 also. There are multiple types, but the most common is type 3 and the 5. And type 3 is very severe condition because it can cause the arterial or the organ rupture. Hyperextensible skin here you can see, and also hypermobile joints. Other conditions, that is a Alport syndrome, involvements of the type 4 type. Next, osteogenesis is a type 1 type that we can see. How can you remember? Remember with the mnemonic of the scap. Type 1 is seen in the skeleton and bones and also skin abundantly, and C for cartilage, A for arteries, B for the basement membrane. Right. Next, airway management. If you find the patient in the bystander, if you don't have any kind of instruments with you, so then you can perform the treble maneuver. So what is mean by the treble maneuver, guys? So first you are going to do the head tilt, and also jaw thrust. Before the jaw thrust, you are going to do the chin lift. So chin lift, head tilt, and the jaw thrust. This is known as a treble maneuver to save the airway. Then we can also proceed for the Goodell's airway. Goodell's airway is to prevent the aspiration and tongue collapse. And next, we can also go for the ET tube, right? Especially you have to use the cuff because the cuff will decrease of the aspiration. It will decrease the risk of the aspiration. Next, other patterns, how we are going to treat this patient. If you are using the nasal cannula, it is going to give rise around 2 to 6 liters of O2 is given. At the rate of FiO2, the saturation levels can be maintained between the 0.24 to 0.45% of the FiO2. And here this is a simple mask, right? So this patient is having the simple mask. In the simple mask, it is going to carry around 6 to 8 liters of the O2, and the FiO2 will be around 0.44 to 0.60. Next, this is the non-rebreathing mask. This is the non-rebreathing mask, and for this patient FiO2 is 0.6 to 0.9, around 6 to 10 liters of oxygen. And this airway, this is the Venturi mask. This is the Venturi mask, and this is having the high FiO2, more than 0.6, more than 6 point, and liters also very high flow. 12 liters of the O2 is also given for this Venturi mask. And what is this one, guys? This is the LMA, like laryngeal mask airway. So we have the first generation and the second generation. First generation will be having the risk of aspiration because only the single valve is present. Second generation is decreased risk of aspiration because it consisting of the two valves. Okay, two valves is seen. Next, chemotoxicity. Chemoman. This diagram is asked, guys. So please do remember this drug. So if it is involvement of the ears and also the kidneys, that is cisplatin and the carboplatin, ototoxicity and the nephrotoxicity. Next, involvement of the peripheral neuropathy, vincristin. Okay, these are the vincristin. Next, bleomycin or the busfulvin. These are the drugs that is going to involvement of the pulmonary fibrosis. Transudimab or the doxorubicin, that is going to cause the cardiotoxicity. Cyclophosphamide, hemorrhagic cystitis. Methotrexate, 5-fluorouracil and 6-metho drug that is going to cause the myelosuppression. And Pulmonary fibrosis is frequently asked question. So it is associated with the nitrofurantoin. It is going to associate with the busfulvin and bleomycin, methotrexate. Okay, methotrexate. All these drugs is going to cause the pulmonary fibrosis. Next, mycology. In the mycology, the question can be asked with the image of these conditions. If you see the pencil-like shape, that is a trichophyton. Okay. Next, if you see this like septate inside this, that is seen with the epidermophyton. And if you see the spindle shape, that is a microsporia. And involvements, trichophyton, it will involve the skin, hair and also nails. Epidermophyton involves the skin plus nails, and microsporum involves the skin and the hair. Next, one by one. So these are the features of the rhizopus, like mucormycosis. This is the aspergillus. So rhizopus will be having the, it does not have the angle like 90 degrees. This is the obtuse angle. So you are going to see like this. Angle is more obtuse and it is going to be septate which is present. Septate is present. Right? Aspergillus is going to have the acute angle and aseptate. Septa is not present here. Here you can see there is no septations. Right? But here you are going to see the septations. That is the difference between the rhizopus and the aspergillus. And drug of the choice for this patient is a lymphotericin, lipoamphotericin B. The drugs can be given for this patient. Aspergillus, the drug of the choice is voriconazole. Recent INCT question. Next, other conditions of the fungus. These are the medullary bodies or the sclerotic bodies seen with the chromoblastomycosis. Right? Drug of the choice for this patient is the itraconazole. Next, here this is the osteoid bodies. Osteoid bodies or the cigar shaped bodies is seen with the sporotrichosis. And here also the drug of the choice is the itraconazole. Next, this is the pink ball appearances, and this stain is a special stain, gomari methane stain, used for the pneumocystis condition. Pneumocystis condition. Drug of the choice is again voriconazole is given for this patient, or also you can give the trimethoprim is given for this patient also. Next, these are the important points, and another one is a cryptococcus, right? Cryptococcus meningitis. Cryptococcus meningitis is specifically India ink positive because presence of the capsule, right? And for this patient also drug of the choice is itraconazole. Itraconazole. Next, last classification of this session, that is a SEEP classification seen with the peripheral artery disease. So the clinical manifestation is important, guys. C1 is for the telangiectasia and reticular veins. C2 is for the varicose vein, recurrent varicose vein. C3 is for the edema formation. C4 is having the three types. A will be for the pigmentation, B for the lipodermal sclerosis, and C for corona polydectasia. C5 is a healed ulcer, C6 is the active venous ulcers with the recurrent active venous ulcers. Next, ABI values, more than 1.3 is falsely high value, more than 0.9 is a normal finding, more than 0.75 is for the mild condition, okay, less than 0.5 is for the moderate, and less than even lower levels is considered as a severe condition. Boyd's grading, type 1 is for the pain which will be relieved on the walking, type 2 is for the walks in the pain, type 3 compelled to the rest, and type 4 is pain at the rest. Okay, this classification can be asked as a potential condition. And please do stay tuned for the upcoming 2 sessions also. Another 100 plus topics we will be discussing. These 100 plus topics is going to be the at least 50 topics we can be expecting, guys. So don't forget to watch all the rapid revision sessions, and also please do practice all these topics that we have discussed. Those who are new to this channel, please do subscribe, share with your friends, and also share this video with your friends. Do like the video. Till then, see you guys. Happy preparation.